Good morning, everyone, and thank you for joining us on day 2 of CV Boot Camp 2021. Yesterday, we surpassed 6,000 views, so thank you all for tuning in. I'd like to thank our course directors, social media ambassadors, and talented DeBakey team for making this possible. We have 2 exciting sessions planned today, and we're going to start with the structural heart disease session, followed by the electrophysiology session. In order to keep this interactive, please feel free to write down your questions or hop in. I'd like to introduce our moderators for the structural heart disease session, Dr. Valeria Duarte, our expert in adult congenital heart disease and cardiovascular imaging, and Dr. Isaac T., interventional cardiology fellow and our former chief cardiology fellow. Thank you for being with us today.
Thank you.
Our first session of the day will be a tour of the heart. Dr. Weiler von Balmus will take us through an exciting tour of the heart. He's an associate professor of surgery and the director of robotic cardiac and vascular surgery.
Welcome to a tour through the heart. My name is Moritz Weiler von Balmus. I'm a heart surgeon, and it's my pleasure to take you through a quick anatomic tour of the heart. So let's get started. The very first thing you want to do is really sort of orient yourself to the heart and how it sits in the body perhaps, but more importantly, really understand which parts of the heart you're looking at. The easiest way is to sight it down and then look for what's obviously the LAD. So look for the structure, the LAD, that separates the left and the right ventricle. So the only thing left now is to figure out which is the left and which is the right ventricle. The right ventricle is obviously the one to the right side, anatomically speaking. So left here, but right anatomically speaking, and where the PA comes off. The PA comes off in the front as opposed to the aorta, which is in the back. So this is the right ventricle. So once we have that, a good way to get started with the dissection is really find the SVC-IVC junction sort of as a hinge point. The first structure I want to draw your guys' attention to is really the fossa ovalis, which is seen here. A lot of the pigs, as well as about 25% of humans, of course, have the permanent foramen ovale, which is a communication between the right and the left atrium. Down here, the next structure that's important to point out, I think, is the coronary sinus, which really sits sort of right at the junction between the IVC and the right atrium. So you see here the coronary sinus that wraps around the heart. Then we can turn over and take a look at the right atrial appendage, which tends to be relatively broad-based as opposed to the left atrial appendage. For orientation, this is SVC-IVC. Take the scissors and sort of sit it into the right ventricle through the tricuspid valve. I'm just going to cut down here a little bit to expose the tricuspid valve a little bit better. So now we've taken the right atrial appendage off. Again, SVC, IVC, one important structure that lives here at the junction between SVC and the right atrium is the sinus node. Now, the coronary sinus also is an important structure as it sort of points towards the triangle of Koch. The triangle of Koch is formed by the tricuspid annulus here and the tendon of Torrado, which comes in like this. And at the tip of this triangle, right there, is where the AV node lives. So let's take a quick look at the tricuspid valve. The tricuspid valve has typically 3 leaflets, can have 2 or 4 or more leaflets, but the common configuration is 3 leaflets with an anterior leaflet, a posterior leaflet, and a septal leaflet. Now the anterior leaflet is the biggest one of the 3 leaflets, both in terms of its circumference that it spans as well as in how tall the leaflet is. The posterior leaflet is the shortest leaflet in terms of circumference, but is taller than the septal leaflet, which is longer in circumference than the posterior leaflet, but not nearly as tall. So it's a relatively short leaflet that spans a lot of the tricuspid annulus, while the posterior leaflet spans a very short segment of the tricuspid annulus, but is taller or longer leaflet than the septal leaflet, and the anterior leaflet being the largest in both dimensions, circumference as well as tallness of the leaflet. The other thing that's important about the tricuspid valve is that it is very different from the other aortoventricular, atrioventricular valve, which is the mitral valve, not only in that it has 3 leaflets, but also in a way that the third leaflet, the septal leaflet, has insertion points both on the intraventricular septum, which is not true for the mitral valve, and the insertion point at the annulus is different. First, about the insertion point on the septal wall. This is, of course, something you don't see in the mitral valve, and it explains when you have filling of the right ventricle and displacement of the septum, why the valve becomes very incompetent, because essentially those chordal attachments pull the septal tricuspid leaflet towards the bulging intraventricular septum and renders the valve incompetent. Also, in comparison to the mitral valve, the chordal attachments are much more complex and convoluted. The tricuspid valve tends to have many more secondary and tertiary cords, and so you can see how it's very easy to get entangled with devices or catheters in this subtricuspid apparatus. And as you move down towards the LVOT, you can take a feel and put your thumb onto the septal portion of the tricuspid valve, and you will feel that right there at this junction there's a very little tissue, and you can imagine easily how, if you have again endocarditis, abscess formation around the aortic valve, how this can break through into the right atrium and to the tricuspid valve. From here, let's move on to the right ventricle, and the easiest way to do that is to keep your scissors back and just cut down towards the apex. And one thing I usually like to show here is as you open this up, you see sort of the rounded surface of the intraventricular septum, and it really demonstrates neatly how the left ventricle is sort of your fist, and the right ventricle is hugging the left ventricle and wrapping around it, where the thumb is the SVC and inflow portion, and then my index and middle finger are the PA. So you have the left ventricle, the right ventricle sort of wrapping around it, explaining that intricate relationship between the left and the right ventricle, how they work together, and how important the left ventricular function actually is for the right ventricular function. So there's not too many things really that I usually point out in the RV. It's just a heavily trabeculated ventricle, as you would expect from reading in the anatomy books. From here, we can go straight to the RVOT, and the pulmonary valve really has a trajectory towards the back as the PAs do, as the PA branches into the left and the right main PA and goes behind the other structures. And we can just cut up here, come along the LAD. The pulmonary valve, a semilunar valve with 3 leaflets. Now, let's go over to the left side, SVC, IVC junction. And going through the foramen ovale, if you go straight across, where you will end up in is the left atrial appendage. The other place you typically will end up with a wire or catheter, if you go in, is the pulmonary veins. Here, the right pulmonary main trunk and the left pulmonary vein main trunk. I'm just going to cut across here. So we have taken off sort of our original axis of orientation, SVC, IVC. There's a little bit of IVC hanging. As you remember here, what you're looking at is the coronary sinus. And so if we look down into the left atrium, we see the base of the left atrial appendage. The next step usually is to cut off the left atrial appendage so we get a good look of the mitral valve. And the easiest way to do this is to sit the heart up and look straight down at the mitral valve. So again, for orientation, IVC, SVC, this is sort of the axis. And the interatrial septum used to live here, sort of coming into plane. So let's take a quick look here at the mitral valve. Two leaflets, anterior and posterior leaflet. What I'm looking at here is what's called the surgeon's view. In the surgeon's view, the aorta is in the front. This is P1 scallop, P2 scallop, and then over here is the P3 scallop. The same in the front, A1, A2, and A3 scallop. Take your scissors and cut straight down like this. So P2, the A2, anterior 2, the anterior second scallop of the mitral valve. And as you can see, you have part of the aortic valve, and here the non-coronary sinus, which terminates right there. And then you have this fibrous tissue before you get to the hinge point of the mitral valve. And this part here is the aortomitral curtain. Same over on this side. You see more of the non-coronary sinus. And then if you pull that down, you see the aortomitral curtain here, starting below the fibrous structures that suspend the aortic valve and going into the anterior mitral valve leaflet. Here, we obviously already made kind of our entry into the left ventricle with primary cords that go to the leaflet edge, secondary cords which insert just behind the primary cords. Let's turn our attention now to the aortic valve as a final step. Since we're back here and in surgeon's view, again, this is P1, 2, 3, A1, 2, 3, and right across from that, if you will, if you cut through the aortic valve, is the right coronary artery. The right coronary artery does actually come off relatively straight in the front, while the left coronary artery is here and dives back to go underneath the PA, which is right here. So we have the left main ostia, and this is the PA coming in, splitting into the left main trunk of the PA, and right behind there is the left main coronary artery splitting into the circumflex, and then the LAD. The aortic valve is suspended in different points. One's at the commissures. There's 3 commissures for the 3 leaflets. There's a right coronary sinus and the right coronary sinus leaflet, a left coronary sinus with its leaflet, and then again, mostly towards the back end, the mitral valve is the non-coronary sinus and leaflet. Thank you so much again for your attention and for taking this tour through the heart with me here today. Again, if you have any questions about how to replicate this dissection, if you have specific questions about how to find the anatomy or how to make your cuts and point out different structures, do not hesitate to contact me by email or through social media. Happy to help you guys out to replicate this at home. Thank you.
Thank you, Dr. von Valmus, for a fascinating tour through the heart. We encourage you to try to work with specimens if you have the opportunity at your home institution. Spend time in the OR and the pathology lab following up on patients that get operated on. That's very enriching and helps putting everything together.
All right. Our next talk is all about adult congenital heart disease, and I can't think of a better speaker than our own Dr. Valeria Duarte to walk us through the important tips and pearls related to this fascinating specialty.
Hello, welcome to our DeBakey CV Fellows Boot Camp. We're going to start with our adult congenital heart disease section now. My name is Valeria Duarte. I'm one of the adult congenital cardiologists and cardiac imagers here at the Houston Methodist. It is a pleasure and an honor to accompany you in this journey. Let me preface this talk by situating you in the current landscape of congenital heart disease. There are approximately 1.4 million adults living with congenital heart disease in the US. Most of the patients that are born with congenital heart disease, which is the most frequent congenital defect, now survive into adulthood. This is different from what it was 30, 40, 50 years ago, and it's different from what it will be in the next few decades. So this population is growing. We now have more adults than children with congenital heart disease, and the growth is estimated to be around 1% per year. So you, as the younger and newer generation of cardiologists, will see many more of these patients that your predecessors a few decades back. I would like you to be familiar with these guidelines. These are the 2018 AHA-ACC Adult Congenital Heart Disease Guidelines. They're easy to read, and they're to the point. The indications are easy to follow. So I strongly recommend that as you see patients with congenital heart disease, you take a moment to look these guidelines up and read about the conditions and the recommendations. I think that's the best way to learn. Congenital ACHD is a growing and blossoming subspecialty. It's very exciting, in my opinion, with very complex hemodynamics and great imaging. So I encourage you to consider it as a career pathway, and if you ever want to talk about it, I would be happy to discuss with you career pathways and so forth. So the guidelines classify adult congenital heart disease into by complexity. So we have 3 categories: simple, moderate, and great complexity. Simple disease involves small atrial septal defects, small ventricular septal defects, mild pulmonary stenosis, and some repair conditions. So an ASD or a VSD or a patent ductus that were repaired. So these will be patients with simple conditions. All of them need follow-up. That's important to know, especially if the surgery was remote. Then moving on to moderate complexity, that's where most of the conditions that you may have heard of fall. So some examples: anomalous pulmonary vein connection, anomalous coronary artery origin, AV canal defects, coarctation of the aorta, Epstein anomaly of the tricuspid valve, ostium primum ASD, also subvalvular AS, subaortic membranes, for example, repair tetralogy of Fallot, that's a well-known one, and larger VSD. So those are the moderate complexity patients. All of them need to follow with a congenital heart disease cardiologist long term. Even if they're repaired, these patients need lifelong follow-up because most conditions can have long-term complications and they need surveillance imaging and clinical assessment to detect this and fix them before they cause structural damage. Okay, great complexity. We're not going to talk a lot about this, but this involves cyanotic congenital heart defects. These may be defects that were completely unrepaired, or they were palliated, meaning they had surgery to improve the pulmonary flow, for example, but they're not fully repaired. We have here also the single ventricles and the patients with Fontan operation. We are not going to discuss this in detail. This is a very extensive topic, and it would take us a full separate talk or a few separate talks. But I just want you to be aware that our patients they're born with a functional single ventricle, so meaning they're missing a second ventricle, and they can survive into adulthood thanks to an operation that's called the Fontan operation. So I just need you to be aware that is the case, and hopefully you'll see patients with this complexity in your practice and have the opportunity to learn more about them. Transposition of the great arteries are here, both D loop and L loop transposition. Truncus arteriosus and other more complex conditions like heterotaxy are there too. I believe the best way to learn is by reviewing cases. So let's review a few cases together to illustrate these conditions. So the first patient is a 36-year-old with hypertension and a dilated aortic root on echocardiogram. So here you can see before we play the video that the root is dilated, all right? And then hopefully you can see here well enough to identify that this is a bicuspid aortic valve, okay, a bicuspid aortic valve. So we have a patient who is very young to be hypertensive, so that should ring a bell, that has a dilated aortic root and that has a bicuspid valve, okay? All right, so when we find that combination, we need to make sure the patients don't have associated coarctation. All right, so this patient did. So remember, bicuspid aortic valve, coarctation of the aorta, and aortopathy, we can frequently find them together. So coarctation, like in this case, was diagnosed by MRI. You can see the narrowing in the descending aorta, and you can see the ascending aorta that is significantly dilated. We can diagnose coarctation with echocardiogram. We don't get to see the anatomy as clearly in adults, but we can measure the velocity in the descending aorta and see the flow pattern. So the diagnosis can be made by echo and confirmed by cross-sectional imaging with MRI or CT, and also the cross-sectional imaging is helpful to plan intervention. So this is an example of a CT angiogram. You can see these patients also can develop collaterals. You see here the significant coarctation in collaterals. Collaterals are trying to compensate for the obstruction, bypass the obstruction, and to supply blood flow for to the aorta and the vessels, the aortic branches distal to the stenosis. 3D reconstruction for that, and this is a patient with very significant collaterals. These are very impressive images. All right, so how do we repair coarctation? So when it's significant enough that it requires intervention, we can repair this in the cath lab with stent. Like in this case, you see the coarctation site here before, and this is after a stent was deployed with a very nice result. They can also be repaired surgically. Not all the patients are candidates for percutaneous intervention. So these are just some examples. There are many other modalities of how this can be repaired surgically. More frequently these days we do end-to-end anastomosis. Important to know that patients with patch augmentations need to be monitored for aneurysms. So in summary, what do we look for in our patients with coarctation? Hypertension. Up to 80% of them have hypertension, and this is even in patients with an excellent repair. Bicuspid aortic valve, and we look for stenosis and regurgitation. Patients that have undergone repair, we surveillance for recoarctation. Around up to 11% of the patients may require reintervention for restenosis. So that's why in clinic we pay attention to the pulses. We make sure there is no delay between the radial and the femoral pulse. We also check blood pressure in the upper and lower extremities and make sure that that there is no significant difference. And we do surveillance cross-sectional imaging of the aorta because patients with coarctations, they have an abnormal aorta. They have aortopathy, so they need to be monitored. There is an association with cerebral aneurysm, so the guidelines recommend that these patients are screened with a CT, the brain CTA or MRI once in adulthood. All right. Okay, let's move on to shunt lesions. So I have a practical rule to share with you. Whenever you discuss a shunt, meaning atrial septal defects, ASDs, ventricular septal defects, or VSDs, patent ductus arteriosus, or PDA, and other some more complex like ostium primum ASDs, sinus venosus, aortic pulmonary windows, anomalous pulmonary vein return. In all those cases, you're going to have to assess what are the consequences of that shunt, the degree of shunting, to make a clinical decision as to whether the defect needs to be fixed or not. So, important to know, if the shunt is above the tricuspid valve, the shunt level is above the tricuspid valve, then the patients will have right ventricular dilation. If the shunts are below the tricuspid valve, then the patients are going to have left ventricular dilation. Examples of shunts above the tricuspid valve, ASDs. A clear example of shunts below the tricuspid valve, VSDs, and also PDAs, patent ductus arteriosus. Okay. So a few imaging examples here. This was a 49-year-old patient with palpitations. We can see here that the right ventricle and the right atrium are significantly enlarged. You can even compare it with the left ventricle there. And then you can see that at the level of the atrial septum, there is a left to right shunting crossing the septum. So this is a secundum ASD. So what's the difference between a secundum and a primum ASD? So we can be very simplistic about it. It's much more complex than that, but just as an introduction, location is important. So secundum ASDs are usually located in the fossa ovalis or near the fossa ovalis. So this is at the base of the atrial septum, at the middle portion. And primum ASDs are located more apically. That means closer to the mitral and the tricuspid valve, okay? So what do we look in the imaging reports when we're assessing for a defect? We look at how big is the defect, we look at the rims around the defect, and we'll see why that's important, especially in secundum ASDs. We look at the QP-QS. QP is a pulmonary blood flow. QS, the systemic blood flow. We can measure them with a cath or with MRI. If it's more than 1.5, more or equal to 1.5 to 1, that's considered hemodynamically significant. And then we look at the right ventricular size, right? So when do we repair? We don't repair all the defects. Sometimes they're very small and not hemodynamically significant, and we don't. We need to assess pulmonary pressures when we're trying to make a decision. Patients with significant pulmonary hypertension should not have their defect closed. So we refer patients for interventions when they have symptoms, or when they have right atrial or right ventricular enlargement, or a QP-QS that is over 1.5. The same criteria applies also for primum, sinus venosus, and coronary sinus defects. The difference is that these are always surgical. Okay, so secundum ASDs can be percutaneous or surgically intervened upon. Patients without symptoms, we consider them for an intervention if they have RA and RV enlargement, and if the QP-QS is hemodynamically significant. And also we consider closure in patients that are going for surgery, cardiac surgery, for other reasons. When not to close, when there is significant pulmonary hypertension. Just a word on percutaneous closure is important in imaging to analyze the size of the rims, because that's where we're going to anchor the devices. The devices are deployed through the femoral vein up the IVC. Once they reach the right atrium, they cross to the left atrium. The first disc is deployed, then on the left atrial side, then the second is deployed on the right atrial side, and then the device is released. Patients that are candidates for this are patients who have appropriate rims. They're big enough to anchor the device, and who meet criteria for intervention otherwise. Just an image of a primum ASD for you to see once and not forget. We said the defect is more apical, closer to the AV valve, so you can see it here. And then just an image of a sinus venosus defect. It usually involves one of the vena cava, in this case the superior vena cava, as is entering the RA, and they're associated with anomalous pulmonary vein return. They're easy to miss, so they're frequently missed. One of the most frequent referrals we get for very dilated right-sided chambers without a shunt identified, they're surgical. And then a word on ventricular septal defects, and we're done. There are very small restrictive defects, usually with very loud murmurs, that are not hemodynamically significant. QP-QS less than 1.5 without LV dilation. Usually we leave those alone. And on the other extreme, we have very large ventricular septal defects that with associated pulmonary hypertension, and sometimes shunt reversal from left to right to left, leading to cyanosis in Eisenmenger syndrome patients. And then in between, we have patients with moderate defects, hemodynamically significant. So these are the ones that we carefully evaluate for closure, and looking at the pulmonary pressures is very important. Even in patients that have had a VSD repair, we should, in childhood, for example, we should look for residual defects like this patient here. You can see the jet here between the left ventricular outflow tract and the right ventricle, right where the arrow is pointing, and that's another view of the same. And as we mentioned, for VSDs, we look at the left ventricular size, and we repair them when there is LV enlargement, a QP-QS that is hemodynamically significant, and no pulmonary hypertension. The same criteria applies to patent ductus arteriosus. The ventricle dilates is the LV, so we repair patients with a dilated LV with a QPQS that's hemodynamically significant over 1.5 to 1. And with that, I'm going to end this talk. I appreciate your attention. I'm sorry it was fast, but we need to be mindful of your time. And if you have any questions, you're welcome to contact me. Thank you.
Thank you so much, Dr. Duarte. That was an outstanding review. What advice do you have for first-year fellows as they start seeing patients with complex adult congenital heart disease?
Well, you will definitely see them during your fellowship. First, don't run the other way. And then ask for help. Know your resources. That's very important, not only for congenital heart disease, for all the subspecialties. Ask for help and then follow through. When somebody else takes over the care, just follow through, read about that specific condition. There is plenty of online material, images, videos that you can use to frame that patient, and then just follow the studies and the decision making, and I think that's the best way to learn. So our next talk is by Dr. Stephen Little. Dr. Little is a professor of medicine at Weill Cornell. He's the director of the structural heart disease program here at Houston Methodist, and he also serves as the program director for the Cardiovascular Fellowship. Dr. Little is going to teach us about mitral valve disease this morning.
I'm Dr. Stephen Little, and welcome to boot camp. I'm going to give you a short talk about mitral regurgitation, focusing on form, function, and mechanisms of valve failure. So if you think about primary mitral regurgitation, there are three types as defined within the Carpentier classification. They're shown here in this quick graphic. Primary MR can be Carpentier type 1, type 2, or type 3. Based on leaflet position, excess leaflet motion, or restricted leaflet motion, respectively. In addition, there are definitions of secondary MR shown here with essentially the same kind of concept with normal leaflet motion or extremely restricted leaflet motion. So it is important to familiarize yourself with this classification scheme. We'll talk mostly about the mechanisms of primary mitral regurgitation. So really what I would like to do quickly is to review normal mitral valve anatomy, relate some of the valve anatomy to common forms of dysfunction, and relate mitral regurgitation quantification to that pathoanatomy. So in considering how the mitral valve works, it is important to recognize that it is more than just leaflet function. These two animations depict that quite nicely. So on the left with the white arrows, we have diastolic inflow. So the mitral valve does have a function in directing diastolic inflow along the lateral and posterior wall so that it can go down to the apex, have a nice vortex down there. And then notice that in the beginning of systole, the anterior mitral leaflet forms a baffle and actually the beginning of the left ventricular outflow tract. So it's not just a valve that's got to get out of the way. It actually has a very important diastolic function in directing flow in the right direction and a systolic function in directing flow in the outflow tract, in addition to being competent and not allowing blood to flow back towards the left atrium. On the right animation, you see sort of a depiction of how the anterior and posterior leaflets move in relation to each other. So posterior leaflet is on the bottom of the image. It really moves backwards and forwards, almost like an airbag, kind of slamming forward with a very dynamic posterior annulus. The anterior leaflet simply falls into the ventricle in diastole and comes back up in systole. So the anterior and posterior leaflets are quite different in the way that they move. This is a depiction of a bloodless animated heart that really shows the important feature of the coaptation length. So this is looking at the coaptation line of anterior and posterior leaflets of the mitral valve, recognizing that I think you can see there's a tissue plane of coaptation. It's somewhere between 5 and 10 millimeters in depth, and then it's not simply a line of coaptation where the tissue comes together. You really need that consistent pressure overlap along the coaptation zone to provide a competent valve. In addition, the mitral valve anatomy is often defined as a complex, not simply a collection of anterior and posterior leaflets. And it's defined as such because you need multiple features for the valve to work properly. You need the annulus, the leaflets, the cords. You need primary, secondary, and tertiary cords, papillary muscles in the right place, pulling at the right time, as well as normal ventricular geometry and function. So all of that, those elements make up the mitral complex. It's called the mitral valve because it was initially named after the bishop's mitre, which it was thought to represent. Recognizing that, again, emphasizing that there's important stuff below the leaflets, just a depiction of an explanted mitral annulus to show the complexity of the cords and how important they are. And we'll talk in a moment about just how those cords work. This is an example of a chordal rupture showing posterior leaflet prolapse. So if you look at a three-dimensional T, you get a good sense of the function of the valve. So on the left is looking down on the mitral valve from the left atrial perspective. Aortic valve is far left, and then anterior leaflet and posterior leaflet as labeled. From the left ventricle, looking up at the valve, you see posterior, anterior, and aortic valves again, sort of showing really the left ventricular outflow tract. So this is a human video, is really to emphasize how closely the aortic and mitral valves are working together. This is, again, a view. This is really more the standard view shown on the left, a normal mitral valve with the aortic valve at 12 o'clock. And you see how dynamic that anterior and posterior leaflet motion is of the mitral valve. In contrast, the image on the right is a case of severe rheumatic mitral stenosis. To highlight a couple of things. In mitral stenosis, there's a diffuse thickening of the leaflet, but also very importantly, there is a loss of the commissures. So over here, the sort of where the smiles would be on the left side and the right side, where the leaflets separate all the way to the annulus. That's the commissure on both medial and lateral sides. In rheumatic mitral disease, those commissures are fused, which has an enormous impact on the inability of the leaflet to now open in diastole. So the heart valve anatomy is very important to consider. I'll give you this slide for reference so you can look back on. But basically, the leaflet nomenclature you'll need to know. This is it as shown on the left. So the mitral valve, bottom left, has P1, P2, and P3 representing posterior anatomy, moving 1, 2, 3 from lateral to medial. Anterior A1, A2, A3, similarly named. The aortic valve is shown with left coronary cusp, right coronary cusp, and non-coronary cusp. And then the tricuspid valve leaflet with septal, anterior, and posterior leaflets named. But the other important anatomic element to consider with the mitral valve is also the fibrous cardiac skeleton that holds the aortic, mitral, and tricuspid valves together. These are the fibrous rings that make up the mitral annulus and the tricuspid annulus, and the crown that holds together the aortic valve. And these are all intimately connected, these three valves. That's something to think about as you look at functional imaging and you consider entities like invasive or destructive endocarditis, which can easily impact all three valves. Now, the pulmonic valve is relatively separated and very anterior, not labeled on the left image. So recognize and learn this cardiac valve anatomy. So the anatomy question, first one is, where are the papillary muscles? This is that depiction of the mitral valve. The aortic valve is shown here. So you're looking through the blue down to the papillary muscles below, and your options are A, B, or C. So option 1, A, the papillary muscles are sort of down through the middle, one under anterior leaflet, one under posterior leaflet. Option B, papillary muscles are basically positioned just under the commissures, equally distributed medial and lateral, and none of the cords, as demonstrated with the black straight lines, none of the cords cross the midline. And then option C, the pap muscles are both under the anterior leaflet, nothing under the posterior leaflet, with most of the cords going to your anterior leaflet and just one or two to the posterior leaflet. So which of those is the correct anatomic organization of the subvalvular apparatus? That's really the question. And if you understand this, you'll understand why MitraClip works and why a lot of the current catheter-based valve interventions actually work out very nicely. Of course, the answer is B. That is the actual organization of the papillary muscles with the anterolateral pap and the posterior medial pap. If you didn't believe me, this is the depiction anatomically. Again, an explanted mitral valve going P1, P2, P3 with commissures labeled. And then the graphic, the cartoon to the right, shows where the pap muscles are immediately underneath the commissures with no cords crossing the midline. So that anatomy is important. And then we have this concept of fibroelastic deficiency, which is a pathologic concept that means why did the valve leak? This is a primary leaflet pathology. The leaflet gets thickened, it gets weak, it has excess tissue, the cords break, and the leaflet becomes redundant, and you get mitral regurgitation. So two different patient examples. The patient on the left, this very mild valve thickening. This might be an elderly patient, probably is not much mitral regurgitation. On the right, you have somebody who's got clear prolapse of the middle scallop of the posterior leaflet, also known as P2, with a little wiggling element there, sort of just at the top of that prolapsing scallop. It very likely represents a chordal rupture. So that's fibroelastic deficiency with chordal rupture. Look at that again in 3 dimensions. This is based on a 3D, sort of showing a bunch of 2D images as well as the 3D view. And all of that to highlight that there are these fundamental sort of etiologies to consider when describing mitral regurgitation. On the top left, we have 2 different examples of primary leaflet pathology. At the bottom left, we have what really would be best termed a mixed. So it's both primary and secondary. It's primary in that there's a primary leaflet thickening and abnormality, but there's also a ventricular remodeling with chordal tension and tethering, and the leaflets don't come together properly. And then the easier one to sort of think through is the primary ventricle problem, also recognized as secondary MR, and that's depicted by the top right image. And you see that leaflets just can't get together because the ventricle is so dilated. And the extreme example on the far right is actually a papillary muscle rupture as depicted with a 3D echo. That's sort of the ultimate in ventricular pathology leading to mitral regurgitation. So this is maybe an easier way to think of secondary MR. If you think of the image on the left, the cartoon shows a normal valve. Pap muscles are in the right place, cords are at the right length. When the ventricle contracts, the leaflets of the mitral valve are together and there's no regurgitation. This patient suffers myocardial infarction. There's remodeling of the lateral wall as depicted by the blue arrows. And now the cords don't get longer to compensate. So now the leaflet is relatively pulled apart because there's been repositioning of this myocardial wall. Cords didn't get longer, and now you have tethering of the leaflet. You can see that in the echo here. There's a little bit of dysfunction over the echo of the ventricular wall. And then when you add the color imaging, which no longer plays, but it seemed to freeze at exactly the right spot, you can see that there is some MR. So the cords are relatively too short. This is a different example. This is a young woman who had myxomatous mitral regurgitation. This is a TEE image. And what does this mean? You see the mitral valve right in the very middle of your screen is big and floppy, and there's going to be some leak. Well, how do we quantify the leak? This, by the way, is a Carpentier type 2 of excess leaflet motion. That's the etiology of this MR. This is a 3D beating view of this valve. And it's sort of a lot happening when it's beating. So I'll slow it down and pay attention to the EKG depicted at the bottom of the screen. In this freeze frame in systole, the aortic valve is open, so that's systole. We're way down here on this line relative to the QRS, so we're quite deep into systole, and you can see that there's a large coaptation gap as shown by the arrow in the mitral valve. So a relatively late systolic coaptation defect. If we look at this sort of color flow, which is a velocity map, it's not a volume map, but it shows the speed of blood. The stuff coming up the screen, and you'll all learn echo, is mitral regurgitation. And one of the challenges is to determine when is it actually happening. Is it happening throughout all of systole, the middle of systole, just the end of systole? All that's important to consider because it does very much impact the quantification of the amount of mitral regurgitation and therefore all of the treatment strategies that follow. So let's look at early systole, mid systole, and late systole. You can see that there is a lot of MR, but it's at the very end of systole. So how do we sort that through in terms of the quantification of MR? And in this case, the coaptation defect takes time. Clinically, we did 3D imaging and looked at a vena contracta, and ultimately we sent this patient for a cardiac MRI, which was able to confirm volumetrically that this was deemed a significant mitral regurgitation. The Doppler also shows it nice that it's quite late though. So here's the QRS at the bottom throughout at least half of systole. There's no measurable mitral regurgitation, and then a lot of regurgitation just at the end of systole. So this is a challenge. In this case, is simply to emphasize that timing is also an important thing to consider when quantifying a valve lesion such as this. And then finally, we need to think about what is the mitral regurgitation actually doing both to the patient in terms of symptoms, but also to the other cardiac chambers. So let's say we have this normal scenario of a normal sized left ventricle, a normal LA pressure, and normal systolic forward stroke volume of 100 milliliters. We have an event such as a papillary muscle rupture, or even easier, a chordal rupture. Now we have a whole bunch of mitral regurgitation. More than 60 mils is considered severe generally. So we have mitral regurgitation. We have a little bit of volume increase of the left ventricle because that flow has to come back. We have an acute increase in LA volume and pressure, and we have a diminished forward flow. But if the patient does okay, they can compensate over time. And then when they get compensated, the LA pressure goes down, largely because of volume increase. The LV increases in volume because that extra flow is accommodated and the LV remodels. And the patient can feel generally quite well because they still have an increased forward flow and a relatively low LA pressure. But then they can become decompensated. The forward flow drops, the LA pressure goes up, and now they feel terrible. And most of our interventions are designed to identify and intervene before they become chronic and decompensated. So an approach to the mitral regurgitation evaluation can look like this in general. You ask the important questions. Why is there MR? And that really refers to the pathoanatomy. When is the MR? You must consider the timing of the systolic event, early, mid, late, or holosystolic. How much MR is there? That's really the exercise of quantification, and you'll learn all about that. And then the consequences, looking at the cardiac chambers and the cardiac pressures. And then finally, the clinical questions. Should this MR be repaired, either for symptoms or for anatomic consequences? And then finally, if you're going to repair it, how do you repair it? Surgical or catheter-based? And that's a little bit beyond boot camp. Thank you for your time and interest.
Thank you so much, Dr. Little, for this informative and comprehensive talk on the mighty mitral valve. Our next speaker is Dr. Sachin Goel, who is a structural interventionalist here at Houston Methodist and also the medical director of structural heart disease. Dr. Goel will be discussing the aortic valve next.
My name is Sachin Goel. I'm an interventional cardiologist here at Houston Methodist, and I've been assigned the task of talking to you about aortic valve disease and provide an overview. Here are my disclosures. Heart valve disease is on the rise. As patients are getting older, we are seeing more and more mitral and aortic valve disease. In fact, studies have shown that the prevalence of significant heart disease is about 10% or higher in patients over the age of 75, with mitral valve disease actually being more prevalent than aortic valve disease. Talking about aortic stenosis, which is the bulk of this talk, as people get older, the incidence of aortic stenosis goes up. And it is estimated that the incidence of aortic stenosis by 2030 will be about 36 million, and by 2040, about 50 million in the United States. The most common form of aortic stenosis that we see is on the left side here, the calcific tri-leaflet aortic stenosis. However, we also see a fair number of patients with bicuspid aortic stenosis, as you can see on the right side here, where they have two cusps with extensive calcification and restriction, leading to severe aortic stenosis. We all know aortic stenosis is not a benign disease. There is a decline in survival once patients have onset of symptoms, which most commonly include shortness of breath, heart failure, angina, and syncope. Based on the most recent valve guidelines, there are 4 stages of aortic valve stenosis, A, B, C, and D. A is patients at risk, B is progressive, C is asymptomatic severe AS, and D is symptomatic severe aortic stenosis. And the cardinal symptoms of aortic stenosis are dyspnea, fatigue, chest pain, syncope, and in extreme cases, sudden death. How do we make the diagnosis of aortic stenosis? Of course, clinical examination is important. These patients have a systolic murmur with a soft or absent S2 and a slow rising pulse. The diagnosis is clinched with echocardiography, and this is a typical example of severe aortic stenosis, where you see the aortic valve is very thickened, calcified, has restricted mobility, as demonstrated here on the parasternal long axis as well as the short axis. The color Doppler, the CW Doppler demonstrates a peak velocity of 4 meters per second jet in this example. So the Doppler assessment includes measurement of the peak aortic valve velocity and gradient, mean gradient, valve area, which is calculated by a continuity equation, and also the important things to look at are the contour of the jet, acceleration time, and ejection time. Sometimes the PDOF probe is very helpful in accurately assessing the gradients by echocardiography. These are the typical changes in the velocity and jet contour as AS progresses. Here's a normal contour of CW Doppler across the aortic valve. And you can see as the aortic stenosis progresses, the velocity and the gradient increase, but also the peak the peak delays in systole, and there's a late systolic peak in patients with severe aortic stenosis. The stages of aortic stenosis, there are three main categories, as we like to see these patients delineate the typical patient presentations and severe symptomatic AS. D1 is the classic severe AS high gradient, where the velocity is more than 4 meters per second, mean gradient is more than 40. D2 is the classic low flow, low gradient AS with low or reduced ejection fraction. In these cases, typically the gradient is less than 40, the mean gradient less than 40. However, with dobutamine echo, you can demonstrate severe aortic stenosis with peak velocity more than 4 and mean gradient more than 40 and valve area less than 1. And then the third category in the stage D is severe AS with low gradient despite normal ejection fraction, or paradoxical low flow severe aortic stenosis. In these cases also you have calculated valve area less than 1, and the gradients are often lower, less than 40. In these cases, important things to keep in mind is that the stroke volume index is often low, less than 35 mil per meter square, and we're using a calcium score of the aortic valve to also further classify these patients into severe versus non-severe. So what about the timing of intervention for patients with aortic stenosis? So this is from the most recent guidelines, which came out late last year. So when patients are symptomatic with severe aortic stenosis, the answer is easy. It's time to replace the valve. What about patients who have symptoms, but their velocity is not more than 4, valve area is, however, calculated to be less than 1? Well, if their EF is low, then they may be the stage 2 or the low flow, low gradient aortic stenosis, and dobutamine may be suitable to assess them. And if they're found to have true severe aortic stenosis, then aortic valve replacement is indicated. We'll talk about SAVR or TAVR in just a few minutes. When you have patients who have stage D3 or the paradoxical low flow, low gradient, if they have low stroke volume and if their CT aortic valve calcium score is high and AS is most likely cause of symptoms, then it is a class 1 indication to consider replacing the valve. What about asymptomatic patients with severe aortic stenosis? Well, if they're asymptomatic but have severe AS, if they have a decline in EF, then it is an indication to proceed with aortic valve replacement. If they're having another cardiac surgery such as CABG or mitral valve surgery or something else, then it is indicated to replace the valve. Or if they have a decline in exercise tolerance with exercise or decline in blood pressure, this is important because a lot of these patients are elderly and sedentary, and they may claim that they are asymptomatic, but when you ask them what do they actually do, you'll elicit symptoms, or the patient's family member will tell you that they really don't do a whole lot because they get symptomatic. So they have curtailed their activities and exercise, so that they're not symptomatic. So the history taking is very important in these patients. So if that is the case, then again, intervention is indicated. In patients who have very severe AS, and they're asymptomatic, but by very severe, we mean velocity more than 5, if their BNP is markedly elevated, or if they have rapid progression and they're low surgical risk, then intervention may be indicated. There are trials looking at asymptomatic severe AS patients, randomizing them to intervention versus watchful waiting. And the results of these trials are awaited at this time. Important part of any AS patients that are seen in valve clinic is also a CT to assess their annular anatomy, the morphology of the valve, the calcification, coronary heights, the root measurements, and also their iliofemoral anatomy to assess suitability for TAVR. Surgical risk assessment, you hear about the STS score. That is one of the most important scores that has been used in all the TAVR versus SAVR trials. Low risk is typically considered less than 4%, intermediate 4 to 8%, and high risk more than 8%. But this is not the only factor in deciding the surgical risk. Frailty has been shown to be an important marker, and then other organ system compromise, such as cirrhosis of the liver, severe COPD with home oxygen dependency, porcelain aorta, and so on, have been also used and in fact are important in assessing surgical risk when evaluating patients with severe aortic stenosis. So just a little background about TAVR. First in man TAVR was performed almost 20 years ago now, in April of 2002 by Dr. Alain Crebier in France. And here are some pictures from that case. This was performed, the patient was awake. Gradient was abolished after TAVR, and patient went home next day. Since then, as you all know, there has been an explosion in the field of TAVR and almost set a revolution in the management of aortic stenosis. Initially, the TAVR trials, both with the balloon expandable and the self-expandable valves, studied patients who are at extreme risk who cannot undergo surgery. This was followed by randomization of high-risk patients to surgery versus TAVR, followed by intermediate risk patients, and most recently, low surgical risk patients in, again, both the self-expandable and balloon expandable valves. And this is sort of the timeline of TAVR. The first TAVR, as we discussed, was performed in 2002. The SAPIEN balloon expandable valve was provided the FDA approval back in 2011. Followed by high-risk approval in 2014, and then subsequently core valve FDA approval for extreme risk and high risk in 2014. And then subsequently followed the approval for intermediate risk patients. And most recently in 2019, FDA also approved TAVR in low surgical risk patients based upon the low-risk TAVR trials. Without going into a lot of detail, I just want to show one slide demonstrating, sort of the timeline of these trials. For instance, in the self-expandable valve category, from extreme risk to high risk to intermediate risk and low risk. And across all these trials, the safety and efficacy of TAVR has been clearly demonstrated. And now the bicuspid low-risk trial has also been published. The core valve has undergone a lot of changes over the last decade, and the most the current version of the Evolute valve is the Evolute Pro Plus, which has a pericardial wrap to decrease the incidence of paravalvular leak. And over the last decade, we've seen improvements and changes in the valve systems and improvement in the delivery, the size of the delivery sheath in both the self-expanding and the balloon expandable valves, which have also contributed to increased safety of these procedures. How do we decide how do we decide surgery versus TAVR? So the heart team decisions are very important, and these are based on different priorities in patients who are being considered for patients who are older versus patients who are younger. For instance, patients who are 80 or older and are being evaluated for treatment for AS, the procedural success metrics that are typically important are, of course, mortality, stroke, PVL, conduction disturbances. Whereas the younger patients who are more active and may have concomitant coronary artery disease or may develop coronary artery disease as they get older, in addition to these features that are important, there are other specific things that become very important, including lifetime management strategies, the hemodynamics, because they're going to be more active, the patient prosthesis mismatch, durability, life expectancy, and of course, coronary access in the future, and also possibility of TAVR and TAVR. All these things become more important as we evaluate younger and younger patients. So there's a lot of data, and based upon all this data, that the most recent guidelines have come up with some frameworks for consideration for SAVR versus TAVI. Patients who are younger, who may have a bicuspid valve in addition to, say, for instance, an ascending aortic dilatation, or have some other features which make TAVR a high-risk procedure, may be more favorable for SAVR. On the other hand, patients who are older, are at higher surgical risk, are certainly better candidates for TAVR. Patients where there is significant multivessel coronary artery disease, which requires bypass grafting, may be suitable for CABG and SAVR, whereas patients with significant calcification of the ascending aorta or porcelain aorta may be more suitable for TAVR. So there are individual characteristics of patients which are important to keep in mind in addition to their surgical risk while figuring out what is best for them. Again, patients with significant lung disease, liver disease, or renal disease, in these patients, TAVR may be more favorable, just as patients who have significant frailty. It is also important to keep in mind there are some features which favor palliation when patients are not very functionally active, they have severe dementia, they have multi-organ failure, and their life expectancy is less than 1 year. These patients may be what we call cohort C patients, and it may be best to not treat them with TAVR or SAVR, but offer palliation. Again, procedural risk is important. Patients who have low surgical risk but have high TAVR risk due to anatomy may be more suitable for SAVR. On the other hand, if the TAVR risk is low or medium, and if the SAVR risk is higher prohibitive, then TAVR may be more suitable. So this is an individualized heart team approach that is taken into consideration while evaluating these patients for TAVR or SAVR. Without going into all the trials, I just wanted to briefly share some of the meta-analyses. This was a meta-analysis published in the European Heart Journal of all the TAVR randomized studies ranging from high, intermediate, and low risk. So this slide shows the mortality outcome. Based on this meta-analysis, there was a signal to superior mortality or survival in favoring the TAVI compared to surgical aortic valve replacement. This includes the high-risk balloon expandable, self-expandable trials, and also the low-risk Evolute and partner trials. What about subgroups? When you look at high, intermediate, low risk, and the access route, transfemoral versus transthoracic, and also the valve type, the only thing that stands out is patients who had transfemoral TAVR. In these patients, there was a signal towards improved survival in the TAVI group compared to surgical groups. In all the other groups, they were felt to be equivalent. What about stroke? When you look at overall stroke, any stroke, there was a signal in this meta-analysis favoring TAVI, less strokes in the TAVR population compared to SAVR. When you look at disabling stroke, there was no difference. This seems to cross the line of unity. Things such as aortic acute kidney injury, new onset AFib, major bleeding, these have been shown to be higher in the surgical aortic valve replacement group compared to TAVR group. The currently approved TAVR devices in the United States are Evolute Pro and the SAPIEN 3 system. The Lotus valve has been recalled and is no longer used. There are ongoing randomized trials looking at the Accurate Neo valve and Portico valve, which we are participating in. And here is a typical example of what the valve looks like pre and post TAVR. As you saw earlier, this is the short axis and the long axis view of the severely calcific degenerated aortic valve and post TAVR appearance of the valve by echocardiography. In terms of TAVR complications, there are complications that can happen with TAVR. The big five, as I like to think, are stroke, bleeding, heart block and pacemaker requirement, acute renal failure, and PVL. We have seen significant improvements in the rates of PVL, renal failure, and bleeding over the last 10 years. The stroke rates, interestingly, have remained constant, about 1.5% to 2%. There's a lot of research going on into the role of cerebral embolic protection in reducing risk of stroke. The risk of pacemaker is still about 1 in 10, and there is some research going on in this field as well to lower the risk of pacemaker, particularly with the self-expandable valves. Bicuspid aortic valve is very important. Patients often have ascending aortic dilatation, and these ascending aortic size, of course, and the valve anatomy is taken into consideration when deciding what is best for those patients. Heart team approach is critical when evaluating patients with valve problems. Patients, of course, at the center, and then patients are seen by interventional cardiologists, imaging, heart failure, anesthesia. We have a cardiac surgeon, of course, and dedicated coordinators, nurse practitioners all participate in weekly valve meetings to discuss these patients. Again, the estimated global structural heart burden is estimated to grow, as is the volume. Aortic regurgitation, briefly, there are various causes of aortic regurgitation. There are cusp or leaflet abnormalities, including bacterial endocarditis, bicuspid aortic valve, myxomatous degeneration, traumatic, root abnormalities such as those seen in patients with Marfan syndrome, syphilitic aortitis, Ehlers-Danlos, and connective tissue disorders, And then, of course, in patients with severe hypertension and coarctation can present with severe aortic regurgitation. Briefly, the management of aortic regurgitation, of course, depends on presence of symptoms. If there is severe aortic regurgitation and symptoms, the treatment is valve replacement or repair. In patients who are asymptomatic, there are several things that are taken into consideration, including the LVEF, the LV end systolic and end diastolic dimension, and of course, the surgical risk. Transcatheter therapies for aortic regurgitation are under construction, and we are participating in the JenaValve trial looking at TAVR for pure native severe aortic regurgitation. I thank you for your attention.
Thank you so much, Dr. Goel, for such a superb and comprehensive introduction. Next, we are going to learn about surgery for valvular heart disease. Dr. Thomas McGillivray, who is the Chief of Cardiac Surgery here at the Houston Methodist and the Chief of Thoracic Transplant and Congenital Heart Disease. He's also a Professor of Surgery at Weill Cornell. He's going to walk us through an introduction of the intricacies of valvular heart disease. Dr. McGillivray.
Hi, welcome to Houston Methodist. I'm Tom McGillivray. I'm a heart surgeon, and I'm going to be speaking with you about the surgery for valvular heart disease. All four of the heart valves can become diseased and can be accessible to the surgeon or to the interventionalist. There are a number of different conditions that can affect the valve and affect the health of the valve, the heart, and the whole patient. But just because a valve is not normal doesn't necessarily mean it needs to have surgery. I would strongly encourage all of you to become quite familiar with the clinical practice guidelines. These practice guidelines provide the evidence base behind how we think about valvular heart disease, how we manage them medically, and when and how to intervene when they need surgery or catheter intervention. A very important component of that is the use of the multidisciplinary heart valve team. This brings together clinical cardiologists, imagers, interventional cardiologists, and cardiac surgeons who all bring their particular expertise to the individual patient to help guide what and when to intervene. Part of that assessment involves the assessment of risk. There are a number of different risk tools, including the Society of Thoracic Surgeons online risk calculator. Individual patients' data can be entered, and from that calculator, a pretty good assessment of what the risk of mortality and the major risks of morbidity are for each individual patient. Surgery involves commonly a median sternotomy, which still continues perhaps the most flexibility for exposure using conventional surgical tools and cannulation for bypass. More and more, we're using minimally invasive techniques, whether it's smaller sternotomies, thoracotomies, or even robotic approaches to the valves. For open surgery, almost all of the patients will require cardiopulmonary bypass that will keep the patient safe for us to stop and open the heart and do the repair or the replacement. For many conditions of the valve, particularly those that are stenotic, there are a number of different options on how to replace the valves. The mechanical valves offer the best long-term durability, but they do require lifelong anticoagulation with Coumadin. There are bioprosthetic valves that are either stented, stentless, or valves that are homografts that come from human cadavers. They don't require lifelong anticoagulation, but they do not have the same long-term durability as a mechanical valve. You may have heard of the Ross procedure, which is a surgical technique to replace the aortic valve. The aortic valve and the aortic root are excised. the pulmonary valve and pulmonary root are moved over into the aortic position, and the pulmonary valve and root are replaced with a cadaveric homograft. This may offer longer-term durability without the need for anticoagulation, but it also has the potential to replace single valve pathology with two valve pathology. With the help of the guidelines, depending upon the patient's age, condition, and risk, you can help navigate what kind of valve choice would best suit your patient. Mechanical valves require lifelong anticoagulation, and trying to strike the right balance between having appropriate anticoagulation and avoiding this thrombosis and thromboembolic complications, whereas avoiding over anticoagulation and resulting in bleeding complications. Bioprosthetic valves don't require lifelong anticoagulation, but do and will have structural valve degeneration over time, resulting in valve dysfunction. So regardless of how you replace a valve in any of the positions in the heart, the patients are put in a situation between a rock and a hard spot, whether it be durability issues or bleeding and thromboembolic issues that over time can and do result in morbidity and mortality for the patient. Each patient that has a valve replacement is also at an increased risk of developing endocarditis, infection of that prosthetic valve. Infections can involve the native valve, which fortunately are commonly able to be treated with antibiotics. If the patient develops destruction of part of the valve resulting in structural heart dysfunction, the valves can be operated on and reconstructed commonly with either a patch or some usual reconstructive techniques. Prosthetic valves that get infected oftentimes usually need to be replaced. This is a patient who ended up with a fungal infection in their aortic valve prosthesis that resulted in destruction not only of the valve, but of the surrounding root tissue. That had to be radically excised, debrided, and the aortic root reconstructed with a homograft. Stenosis and infections aside, whenever possible, we prefer to try and repair valves in the heart. About 40 years ago, Professor Alain Carpentier from France introduced us to the understanding of the mechanisms of mitral regurgitation. And if we understand what the mechanism of the regurgitation is from, then we can often surgically repair and reconstruct the valve. A simpler way to think about Carpentier's classification system is looking at the mitral valve and seeing if there's issues with the annulus, whether it be dilated or restricted or calcified, problems with the leaflet, whether they be elongated cords, ruptured cords, elongated leaflets, or fibrotic leaflets, or problems associated with the ventricle itself, like we commonly see with ischemic cardiomyopathies resulting in ischemic mitral regurgitation. This is an intraoperative view of a patient who has a dilated mitral annulus, resulting in poor coaptation of the anterior and the posterior leaflet. That mitral annulus can be tailored using an annuloplasty ring, recreating the normal size and geometry of the mitral annulus with normal coaptation of the mitral valve cusps. In a patient that has ruptured cords, the traditional quadrangular resection, cutting out the affected portion of the valve, mobilizing the posterior leaflet, sewing it back together. This is an intraoperative photo of that elongated P2 portion with ruptured cords. That portion is excised in a quadrangle and reconstructed with sutures, restoring the valve geometry and valve function. More and more, we try to respect rather than resect valve tissue using Gore-Tex sutures to reconstruct the chordae tendenii or sewing the different leaflets back into a more functional position. Mitral valve repair compared to replacement is associated with better left ventricular function, with results in improved long-term survival and greater freedom from endocarditis, thromboembolic complications, and bleeding complications related to anticoagulation. And here, graphically represented as improved long-term survival of repair over replacement. The one exception to that may be ischemic mitral regurgitation. There have been a number of controlled randomized trials showing that mitral valve replacement is better than mitral valve repair in a composite fashion in patients with ischemic mitral regurgitation. With regard to aortic valve regurgitation, we have taken some of the same concepts and tried to bring it to the aortic valve. For those of you who have seen the echo of the aortic valve, we commonly refer to it as the Mercedes-Benz sign, when in fact we should probably be thinking about it as the Burger King crown sign. The aortic root is a three-dimensional structure. The function of the valve is very dependent upon the precise geometry, the form, if you will, where the function follows that form. Just like Carpentier described the function of the mitral valve, El-Khoury has created a classification system to help us better understand the dysfunction of the aortic valve, whether it be due to dilation of the sinotubular junction, the aortic ventricular junction, or the cusps themselves. Looking at the specific dysfunction of the valve, whether it be with the cusp, the sinotubular junction, or the ventricular aortic junction. If there's prolapse of the aortic valve cusps, we can raise the vertical height with sutures. The ventricular aortic junction can be tailored and secured with either a ring or a graft into which the scalloped commissures can be sewn into that graft, all with the effort to precisely reconstruct the geometry of the normal valve so that the function of the valve is normal. We are very dependent upon accurate echo assessment of the valve preoperatively so that we can get an idea of what the mechanism of the valve dysfunction is. And immediately after our repair, we use the transesophageal echo to make sure that we have reconstructed the valve properly and that the function of the valve is acceptable. In summary, valve replacement is safe and very effective for a number of different valve pathologies, but it is associated with long-term morbidity and mortality, mostly related to problems with durability or problems related to anticoagulation, whether it be thromboembolism or bleeding complications. All valve replacements have an increased risk of endocarditis, which over time has an increased risk of morbidity and mortality. When possible, we like to repair valves because it is associated with excellent long-term freedom of mortality and morbidity. Perhaps the exception to that rule would be ischemic mitral regurgitation. I would strongly encourage all of you to use evidence-based decision-making in how we assess, manage, and intervene on patients with valvular heart disease, and using the guidelines to help direct our therapy will allow us to not only take care of our individual patients, but better understand how to take care of future patients. Once again, welcome to Houston Methodist, and thank you for your attention.
That's from another camera.
Thank you so much, Dr. McGillivray, for this introduction to surgery for valvular heart disease. We're going to switch gears to transcatheter interventions, and we're going to highlight a few of the devices that are commonly used to treat valvular heart disease. We're going to start with the MitraClip device, which is a device that is FDA approved for management of primary severe mitral regurgitation and secondary mitral regurgitation. This is the MitraClip delivery system, which allows the operator to maneuver and adjust the position of the clip. The clip is usually at the end of this delivery catheter, as you see here. This procedure is done via the transeptal approach. So it starts with getting venous access and then a transeptal puncture from the RA to the LA. Then the device is advanced into the LV and used to approximate the anterior and posterior leaflets. This is also done under echocardiographic guidance. Patients have severe mitral regurgitation and need to have good anatomical characteristics for this procedure to be successful. In patients with secondary mitral valve regurgitation, remember that the goal is to optimize medical therapy before consideration of transcatheter edge-to-edge repair with this device. The next device we're going to highlight is the Watchman device, which is a left atrial appendage occluder, and it's used to treat atrial fibrillation, prevention of left atrial appendage clots in patients who are at a high bleeding risk. This is again a procedure that is done through a transeptal approach. Okay? I'm going to show the device. Yes, that's the device. It's a transeptal approach, and this device is deployed in the left atrial appendage, os. Of course, before the procedure, you have to get accurate measurements of the size of the left atrial appendage, either by TEE or CT. And patients have to be on anticoagulation for 45 days to allow endothelialization to happen before they can be taken off of their anticoagulation. So this is a device that's used for management in patients who are at a high risk for bleeding, for the prevention of thromboembolic events in patients with AFib. Dr. Duarte will now feature some of the congenital devices that are commonly used.
Okay, so this is a delivery system for a septal occluder device that is used to close a secundum atrial septal defect. As you can see, this is the catheter that it's used for delivery. The access is usually the femoral vein. The catheter is advanced up the femoral vein, up the IVC, all the way to the right atrium. Once the catheter reaches the right atrium, the septal defect is localized and crossed to the left atrium, and then the left atrial disc is deployed and pulled against the atrial septum. Once the position is right, a second disc on the right atrial side is deployed. Once the position is optimized and confirmed by echocardiography in Cine, then the device is released in its position. There are different sizes of these devices. This is a smaller one. I'm going to show you there are much larger ones for larger defects, and the different manufacturers have different technologies and systems. So this is another occluder device from another manufacturer. This is how it looks once it's implanted in the septum. All right, so those were all the devices we wanted to share with you today. Now we're gonna move on to give you a well-deserved break, so you can be rested for our last session, which is a focus in electrophysiology. So please tune in again at 11:05 for the last session, which will be very important to survive your first year and your night calls. If you missed any of the talks this weekend, or you would like to review one in particular, you're welcome to subscribe to our YouTube channel. All the lectures will be available there for you. Thank you again for spending the morning with us.
Hi everyone, my name is Paul Sherman. I'm a cardiac electrophysiology and I'm here with Dr. Peter Rothstein. And we'll be starting the last session of the day, session 5, which is cardiac electrophysiology. We just finished an amazing session, the structural heart. And we'll be getting ready for our first talk. We'll be on the basics of bradyarrhythmias and pacemakers. Please feel free to text any questions and we will answer through the videos. And Dr. Amish Dave will be the first presenter. So please go ahead.
Okay, thank you. I'm going to talk about bradycardias and pacemakers. Bradycardias can happen, well, basically it's defined as a heart rate less than 60. It can happen from problems at the level of this AV node, sinus node, or below the AV node. And it produces symptoms that you can guess, like lightheadedness, fatigue, syncope, or near syncope. In general, the EKG diagnosis for bradycardias is, based on trying to identify where the site of block is. Is it at the level of the sinus node, in which case there are insufficient P waves? Is it at the AV node, in which case you may have Wenke block or Mobitz 1 block? Or is it below the level of the AV node, in which case you may have second degree Mobitz 2 block, which you see over here, or third degree block. In general, with the infrahisian blocks, your escape rhythm or your ventricular rhythm is a wide QRS, and those are generally, imminently life-threatening potentially. So when you see any of these things, when you see a bradycardia on telemetry, you get consulted for bradycardia, it's a very good idea to try to dig a little bit further than just say bradycardia and try to say whether this is sinus asystole due to sinus arrest or asystole due to AV block or both. I mean, if you see pauses on telemetry and you see P waves slowing down and prolonging PRs, you've identified that the problem is at both the sinus node and the AV node, which really actually nails down the diagnosis too. This is a vagal event. That's the only thing that could simultaneously affect both. If you diagnose AV block because you see P waves non-conducted during that thing, and the P waves are tachycardic, well, you know it's not vagal because a vagal event would have slowed the sinus node, would have slowed the P waves. So, really, everyone knows the EKG diagnosis of bradycardia, but I urge everyone to look at the bradycardia episode a little bit more in detail than just say it's bradycardia. So the indications for doing something when you see some kind of a bradycardia are basically any symptoms should lead to action. And if you see severe bradycardias that are likely to lead to injury or harm, basically pauses over 3 seconds in sinus or pauses over 5 seconds in AFib or heart rates less than 30, this should lead to action. The action, if it's at the level of the AV node or higher, could be just to reduce or eliminate rate-slowing medications like beta blockers. If it's pauses in the middle of sleep, and only then, and you have a narrow QRS escape, meaning it's vagal due to sleep apnea, even if it's greater than 3 or 5 seconds, it doesn't necessarily need you don't necessarily have to go and give a pacemaker that, in that situation. You probably shouldn't. You should treat the sleep apnea. So once you've gotten to the decision that you want to give a pacemaker, you've gotten there because presumably you couldn't stop rate-slowing medicines to fix the bradycardia, or they needed the medicine, say they needed the metoprolol for obstruction in hypertrophic cardiomyopathy or something like that. Now you've got to give a pacemaker. A pacemaker is at its heart really not much more complicated than a digital watch. It's got a clock in it, a little computer, and a battery. And what it does is it counts down with a stopwatch, and when a timer has come to 0, instead of ringing an alarm, it elicits a little pulse of electricity, a square wave pulse of electricity into the electrodes that are screwed into the heart. And by doing that, it paces the heart. And now pacemakers can also do one more thing, which is they can listen in on the signals from the wire and detect or sense when a depolarization in the heart tissue has occurred, so sense. When the pacemaker decides to elicit a heartbeat, it injects a bunch of current, or in the form of electrons, into the tip of the electrode, which is somewhere in the myocardium. That hyperpolarizes the interstitium, so the inside of the cardiomyocytes, which had been at a resting membrane potential of -70 or so millivolts, are now relatively depolarized to the newly negative interstitium, and that opens sodium channels and initiates the cardiac action potential. The flow of electrons has to go down a cathode and up this anode and get back to the battery. So typically the wires have a tip electrode and a ring electrode. When you look at the result of that, if you are pacing in the atrial channel, you will see after the pacing spike, a paced P wave, and that's what we got over here. If you're pacing the ventricle, of course, you get a paced QRS. If you are putting out a pacing spike and you do not see a depolarization on the telemetry afterwards, that means that whatever amount of current you're putting out is insufficient to depolarize sufficient cardiomyocytes to lead to a depolarization or a heartbeat. You can see from the pattern of the pacing spikes, though, the clock interval, the programmed rate of the pacemaker, and in fact, on this telemetry strip, you can see that the pacemaker actually sensed this second QRS, weighted the programmed rate or the V to V interval, and then released the pacing spike, and then it continued to release those pacing spikes whenever it failed to sense something. So that's the clock aspect of it. There's a terminology that you're going to see, which sometimes is confusing, so I'll go over it. Fusion, when a depolarization happens from the pacing spike, if that's the only thing depolarizing the heart at that moment, the result may be a QRS like what you see on the first beat over here, very wide. But sometimes you'll see variable QRS morphologies, usually narrower than that, resulting from the fusion of the systole resulting from the pacing spike and the normal systole coming from the AV node. And so it becomes somewhat some fusion between the narrow QRSs that are intrinsic and the wide QRSs that are paced. And those are called fusion beats. So getting to sensing, when the pacemaker is continuously analyzing the signals coming in from the wires, there is a certain waveform that results from the atrial or ventricular muscle. The pacemaker has a simple threshold, well, a complicated threshold, but at its heart, it's best understood as a simple threshold that's kind of like a bar. And if the signal, like on the left, is below the bar, the pacemaker doesn't recognize that anything happened in the tissue. If the bar is set too low, then the pacemaker may overinterpret far-field signals from the atrium or the diaphragm squeezing or other signals like the microwave oven as a heartbeat and could potentially cause problems. And then if you have it just right, then it only senses the signal that's coming from the chamber the wire is supposed to be sensing from. So there's a sensing threshold that needs sometimes to be adjusted. When the pacemaker senses a depolarization from whichever wire it's sensing from, it resets the clock. And so if the pacing rate is set to 60 beats per minute, the interval is 1 second. And so in this case, when it paces in the atrium, you see a paced P wave, a conducted QRS. After one pacing interval, there's another paced P wave, conducted QRS. But now in the second pacing interval on the screen, a normal sinus P wave occurred, and that reset the clock. And so the new pacing interval started at the moment the pacemaker sensed the signal from that P wave and resulted in this pacing spike that came in a bit earlier than if this pacemaker had been asynchronous. When the pacemaker does sense a depolarization in the ventricle, it will similarly wait and reset the clock. And this is all very useful because you don't really want to pace in the T wave very often, or you will risk triggering arrhythmia. So the pacemaker over here sensed this intrinsic QRS, reset the clock, and then paced over here. And similarly, we'll reset the clock for that fourth beat. And that will, over time, prevent pacing with too short of an RR interval. Now, problems can occur with sensing, like I suggested. If you set that sensing bar too low, then you can oversense, and oversensing leads to underpacing. So in this case, the pacing interval you can measure and determine by looking at the distance between these two spikes. And the reason it paced where the second pacing spike is because it must have oversensed some signal where the red circle is, the first red circle is, which isn't actually there. And so there was no physiologic thing to sense. Similarly, if you walk back from the fourth pacing spike, you can see that it must have sensed some signal in the tail of the T wave, et cetera. Undersensing tends to lead to overpacing. So here, that bar is set too high, and the pacemaker failed to recognize that these QRSs happened, and instead it put out pacing spikes as if there were no QRS there. And so it is pacing in the T wave. And in fact, you got a PVC in the T wave with the third pacing spike. This is what would happen if you were asynchronous pacing, so there is no sensing. Or, for example, what happens when you put a magnet over a pacemaker, or if the setting was wrong. Now, there's a coding system that oftentimes is alarming and confusing for non-electrophysiologists. The system is a series of letters, typically 3 or 4 letters, that describes in a very succinct way the way in which a pacemaker is going to behave in response to the programming and the signals coming from the electrodes. So every manufacturer will use this, so it becomes a common language for the many manufacturers of pacemakers, and it's sort of a necessary evil. But the way it works is the first letter in these modes, things like VVI or DDD mode, represents the chamber you're pacing in. The second is the chambers you might be sensing in. And then the third is what you will do if you sense something. And the fourth will ignore it. It's either there or it's not. If there's an R there, it means the pacemaker is allowed to adjust the heart rate. If you are pacing in the ventricle, it's going to be a V mode, like a VOO or a VVI. If you're pacing in the atrium, it's going to be an A mode, like AAI or AOO. And if it's pacing in both, then it's D. Similarly, if you are sensing, you're going to have an A, V, or D. If you're not sensing, if you're asynchronous, that's going to be O. So a VOO means pace in the ventricle, don't sense anything. And if you're not sensing, there's no response to sensing. So that third letter has to be O. That's asynchronous pacing. So if you have a patient with a single chamber pacemaker, they're about to get surgery, you put a magnet on it, it moves to VOO mode, so that the electrocautery doesn't inhibit pacing from that device. If you are in DDD mode, you are going to pace in both atrium and ventricle, sense in both chambers. If you sense a P wave, don't pace in the atrium, reset the clock in the atrium. If you sense in the ventricle, don't pace in the ventricle, reset the clock. And if you see a P wave but fail to see a QRS, then go ahead and trigger ventricular pacing after sensing in the atrium. So that's these NBG codes in a nutshell. Pacemakers require leads. In the vast majority of cases, these are transvenous leads. They look something like this. Here we have a right atrial, a right ventricular, and a left ventricular lead. In general, you can have various kinds of leads, some with screws at the tip, some with hooks. There are epicardial leads. Some of these leads are MRI compatible, some of them are not. We have in the last five or so years an option to put in pacemakers that have no leads. So these are pacemakers that kind of look like there's a bullet in the heart. This is one of them, and in general, the newest versions of these types of devices can pace the ventricle while still sometimes maintaining AV synchrony. It has a trick to tell when the P wave occurred. Some of the older versions are purely for asynchronous ventricular pacing. And you'll see sometimes on x-rays leads that look like this, where the pacemaker lead is screwed directly into the His, the bundle of His, or the left bundle branch. And this is for providing physiologic pacing, where we can achieve a normal QRS and normal depolarization of the heart. So there are relatively new things happening in the world of pacing. That's mostly with these leadless pacemakers and His bundle pacing. When you see a QRS that has a pacemaker spike in front of it, interpreting the EKGs has become a lot more interesting since the advent of left bundle branch and His bundle pacing. So with that, I'm going to finish up, and thank you very much.
Hi everybody, welcome back. So that was a fantastic talk by Dr. Amish Dave about pacemakers, very updated. And now we're going to move on to our EKG survival and SVT presented by me.
Hello everybody, my name is Paul Sherman, and I'll be talking about EKG survivals and supraventricular tachycardia. I'm a cardiac electrophysiologist here at Houston Methodist, and we're going to start our presentation about supraventricular tachycardias. What are supraventricular tachycardia? They are considered any heart rate above 100 beats per minute with a QRS less than 120 milliseconds. Once that we establish we're in the presence of a narrow complex tachycardia, we'll determine if they're regular or irregular. If they're regular, we should start thinking in the presence of sinus tachycardia, atrial flutter, AVNRT, AVRT, atrial tachycardia, or junctional tachycardia. If we're thinking in the setting of an irregular, we should be thinking about atrial fibrillation, atrial flutter with variable conduction, or the presence of multifocal atrial tachycardia. Let's talk about an example. This EKG tracing you can see is a narrow complex tachycardia. The QRS is wide, but it doesn't reach more than 120 milliseconds and is regular. So we're more likely dealing with the presence of a sinus tachycardia because of the well-defined P wave. So sinus tachycardia is usually secondary, and we have to start thinking into cardiac versus non-cardiac etiologies. For example, heart failure, myocarditis, and tamponade and acute coronary syndromes are causes of sinus tachycardia, the cardiac etiology. In the non-cardiac, we have anemia, pulmonary embolism, sepsis, hypoxemia, hypovolemia, pain, stress, withdrawal from drugs, pregnancy, hyperthyroidism, pheochromocytoma. The key is to identify the mechanism of the sinus tachycardia, because if you correct it, the sinus tachycardia will resolve. We try to avoid treating with beta blockers and calcium channel blocker, rather treating the etiology that is causing the sinus tachycardia. What about when it's not secondary, what is primary? Well, that is considered a rare, but it can be termed as an inappropriate sinus tachycardia, and it's an exclusion diagnosis, okay? We term inappropriate sinus tachycardia as the presence of chronic, non-paroxysmal resting heart rate of more than 100 beats per minute that is not associated with any physiologic, pharmacologic, or pathologic etiology. It's thought to be a rare condition, but it's very often seen in young females and healthcare professionals. What about POTS? Is it the same as inappropriate sinus tachycardia? The answer is no. POT is often associated also with young females and is common as an orthostatic condition seen after stress. The POT syndrome, the POT is a syndrome that is characterized by a response to a postural changes. So after standing up, if you see the heart rate goes more than 30 beats per minute or higher for 30 seconds, you could be presenting as a POTS syndrome. The presence of the symptoms make it a syndrome. And in individuals between 12 and 19, that has to be more than 40 beats per minute in the absence of dropping of the blood pressure. This is the next step. As you visualize, this is another example of a narrow complex tachycardia, regular, but in this case, we cannot see very well the P wave. However, you look closely to this EKG, you will notice that there are certain deflections that could be a P wave, but they're just follow on the QRS. And they are known in V1 as a pseudo R wave and in lead 2, 3, and AFib as a pseudo S. These are the primary mechanism of paroxysmal supraventricular tachycardia. AV-NRT takes more than 65% of the cases, and AV nodal reentry mechanism. The orthodromic AVRT will be less than 30%, and atrial tachycardia, usually focal, less than 5%. Here we're an example of typical AV-NRT. Slow pathway. Okay, as you can see, there's a block on the slow pathway, and a reentry mechanism happen. You come out of the fast pathway and in the lower common pathway at the same time, and you re-enter in the slow pathway. This is how a slow pathway tends to appear. And this is the way we identify in the EP settings. Here we're doing an extra stimul, and you can see the AH interval is 150 milliseconds with a cycle length of 307. As soon as we pace 10 milliseconds earlier, at 360, you will see an increase up to 320 milliseconds, and that's known as a jump, which means we have gone from the fast pathway to the slow pathway conducting down the AV node. This is we do a plot diagram, and we can see on the white dots, it's as fast as we're going down from 600, and we reach the effective refractory period of the fast pathway, there will be an increase in the response of the A2, H2 response. As you can see, there's a marked increase. That's considered as a jump. And that is suggestive of a dual pathway physiology. What about AV nodal dependent and septal VA time less than 70 milliseconds? As you can see here, the VA time is less than 70 milliseconds. They're occurring simultaneous. Only AV-NRT is able to do that. And as you can see, it's nodal dependent. As soon as the AV node blocks, the SVT terminates. This is another example of infrahesian block during AV-NRT. As you can see here, we have the His marking distally, and there's a lower common pathway block and then 2-to-1 phenomenon. And we've known this as infrahesian block during AV-NRT. What about the variants of AV-NRT? Where the most common type we show it to you is a slow fast, and usually occurs about 90% of the cases, and it's classically the anterograde pathway is the AH, and it's usually more than 200 milliseconds, and the retrograde pathway, which is the fast pathway, is with an HA of 70 milliseconds. That's the classic shortened VA time. Now, the atypical variant is the fast-slow. When we invert, the fast pathway will be the anterograde with an AH of 30 to 185, and the slow pathway, retrograde, will be longer. What about the management of AV-NRT? So AV-NRT usually responds very well to vagal maneuvers or the use of adenosine intravenously. If it's ineffective, you should consider other alternatives, especially if they're hemodynamically unstable. Okay, we should consider synchronized cardioversion, class 1 indication. Otherwise, you should stick with their usual drugs, beta blocker, diltiazem, and verapamil, class 2A agent. If that doesn't work, will be a class 2B, the use of amiodarone. You could consider the use of oral agents of beta blocker and verapamil. However, they are labeled as a 2B indication. The patient has to be hemodynamically stable. What about the indication for catheter ablation? If we have an encounter of a patient with AV-NRT, what are the class 1 indications? Is poorly tolerated AV-NRT, the presence of recurrent symptoms, or 1 episode of AV-NRT, but the patient do not want to take medical therapy, any paroxysmal supraventricular tachycardia with the presence of dual pathway is considered AV-NRT case and could be considered for catheter ablation. Here's another example of an EKG where you can see that you may misclassify as an SVT, and it could be confounding, but if you look closely on the lower panel, when you slow it down, it's actually an atrial flutter. It's a narrow complex tachycardia, regular, and you can see it nicely, the flutter waves on the bottom panel. So it's very easy to miss atrial flutters on EKG, especially when they're 2-to-1, and catheter ablation is the preferred treatment for these flutters, okay? Many times, however, they're associated with AFib, and that has to be taken in consideration. So what can we do to see them on the EKG? We can use adenosine like this example. It's clearly an SVT. It is regular. We don't know which type of mechanism it is. We give adenosine, as you can see, nicely floated wave that was going probably 2 or 3 to 1. What about the treatment? The atrial flutter could be considered rhythm control or rate control. Most of the time we attempt rhythm control, and the first option should be catheter ablation with a class 1 indication. If that is not effective or is not achievable, then we should consider the use of immunol, federal or sotalol. And if that is not an option, then flecainide or propafenol. What about rate control, beta blockers and diltiazem? This is an EKG of atrial fibrillation, as you can see, and now we're going to show you an EKG of AV-nRT. AV-nRT, you can see you have a very well defined P wave in this case, and we're able to see it, a more separation between the QRS and the P wave. This is an EKG with pre-excitation. As you can see, there's a nice delta weight and a short PR. This should bring the idea of an accessory pathway as a potential mechanism. And the pathway can be concealed manifest, and they can go anterograde or retrograde or in both directions. And sometimes the anterograde pathway may put patients at risk for sudden cardiac death. Typically, the pathway directly connects the atrium and the ventricle, bypassing the normal conduction of the AV node and the His-Purkinje system. These are the two mechanisms of the AVRT, the orthodromic narrow complex tachycardia, where you're going down the AV node to the ventricle and you come back to the atrium to an accessory pathway and give you a narrow complex QRS as seen in B1. And you have the antidromic wide complex tachycardia, where you're going down the accessory pathway to the ventricle, coming back up to the atrium through the AV node, and give you a wide complex in V1. This is an example of an AV-nRT antidromic. You can see it's a wide complex tachycardia and regular. And this is an example of atrial fibrillation with pre-excitation. As you can see, it's wide complex, it's irregular, and there are different grades of pre-excitation. Here we have an example of the most common locations of pathways. We have the posterior septal area, the left free wall by majority, then we have the right free wall and the anterior septal. Here's a diagram. As you can see, you're activating both the ventricle through the AV node and the accessory pathway, give you the signs of the pre-excitation. The VA time shortens if you lose the bundle branch block that is ipsilateral to the pathway. In this case, the right bundle went away and our VA time shortens. And also it can terminate the tachycardia. In this example, the right bundle goes away and the tachycardia terminates. What are the type of accessory pathways? Well, we have the atriofascicular, the atriohesian, the nodoventricular, the nodofascicular, and the fasciculoventricular. The most common is the atrioventricular. A unique form of AV-nRT that involves a concealed accessory pathway that is usually located in the posterior septal region and with a retrograde decremental conduction property is known as a PART. Very important because it could be the reason for heart failure in young individuals. And you will see a tachycardia with deeply inverted P wave in lead 2, 3, and AVF with a long RP interval due to the location and decremental properties of the accessory pathway. And it has an incessant nature. What about the treatment? So if you have pre-excitation, yes or no, either way, it could be considered for catheter ablation. However, the medical therapy will change. If you have no pre-excitation, beta blockers with diltiazem, verapamil should be the class 1 indication, and then flecainide, propafenone class 2A, and amiodarone digoxin, federalized sotalol class 2B. Now, if you have pre-excitation, then beta blockers with calcium channel blockers are not ideal, and you should use flecainide or propafenone in the absence of structural heart disease. If you have structural heart disease, then you can use amiodarone, diltiazem, the federalized sotalol, or verapamil. This is another example of EKG you should know, and with this will be the last EKG for EKG survivals. As you can see, it's irregular, it's narrow complex tachycardia, and it has multiple different type of P wave. This is considered multifocal atrial tachycardia. And you need at least 3 different morphology of P wave present, and usually associated with pulmonary disease and pulmonary hypertension, coronary artery disease, valvular heart disease, as well as hypomagnesemia and theophylline. The treatment is managing the underlying mechanism. And thank you very much. With this, I will conclude my presentation and hope you have enjoyed it. Have a great time.
Thank you, everybody. That was wonderful. Now we're going to move on. Now we're going to have Dr. Apur Patel, and he's going to go overview syncope, which is a common presentation that you may have to deal when you're on call. So he will break us the fundamentals to approach this condition.
My topic is syncope and sudden death. And this is something that you guys are going to see a lot during your fellowship. About 40% of people have syncope at least once in their lifetime. And you can see that as the population gets older, the incidence of syncope increases. And by the time you're above 80, it happens in almost 17 to 20% of patients, depending on your gender. Now, your job as a cardiology fellow is to figure out when syncope is dangerous and when it's benign. And when I say dangerous, I mean, is it aborted sudden cardiac arrest? And if you look at this graph, you can see that if you have no syncope or vasovagal syncope, your mortality is basically the same. Whereas if you have an unknown, a neurologic, or a cardiac cause of syncope, these are associated with a lower mortality. So vasovagal syncope is benign. Other types of syncope are more concerning. And when when somebody comes into the ER with syncope, the first thing you have to figure out is it syncope or is it something else? Meaning that, it's what you really see is transient loss of consciousness. Now that's an umbrella term that includes syncope, neurologic etiologies, and miscellaneous etiologies. So for example, there can be seizure disorders, a concussion, psychogenic issues, narcolepsy, low blood sugar, hypoxia, hyperventilation, drugs and alcohol, carcinoid. All of these things can cause loss of consciousness, but they're not syncope. But when we think about syncope, we break it down into 4 buckets. So there's reflex syncope, which was formerly known as neurally mediated syncope. There is, and that includes vasovagal syncope, carotid sinus hypersensitivity, or situational syncope when you pass out when you're coughing, urinating, defecating, things like that. There's orthostasis, which is often due to medications or volume depletion, blood loss, deconditioning, bed rest, POTS that Dr. Sherman alluded to in his prior talk, autonomic disorders. And then there's arrhythmias, which is what we worry about the most. So obviously you can have bradycardia, heart block, SVT, VT, and VF, and we'll get into that a little bit more. And then there's structural cardiac diseases like aortic stenosis, hypertrophic cardiomyopathy, tamponade, myocardial infarction, things like that. So this is the kind of differential you have to run through in your head after you've determined that this is syncope and not some other cause of transient loss of consciousness. And then as electrophysiologists, there are specific things that we're worried about, that we're always thinking about in the back of our mind, that can cause sudden death. So certainly the most common thing that we worry about is structural heart disease, ischemic or non-ischemic cardiomyopathy leading to VT or VF, ventricular tachycardia or ventricular fibrillation. But then there's some inherited arrhythmia syndrome. So there's long QT and short QT syndrome, both of which can be arrhythmogenic and lead to VF. Long QT can be either congenital or acquired. For example, certain drugs can prolong your QT, as you guys know. There's something called Brugada syndrome, which is due to a sodium channel mutation and can lead to sudden death. Wolff-Parkinson-White. There's something that is called catecholaminergic polymorphic ventricular tachycardia, or CPVT for short. And that is usually in young patients who have exercise-induced ventricular arrhythmias due to abnormal calcium handling. It's a genetic disorder. Hypertrophic cardiomyopathy. There's something called arrhythmogenic right ventricular cardiomyopathy, which can be genetic and causes fibro-fatty replacement of your myocardium, which then leads to VT and VF. And then there's early repolarization and idiopathic VF. So before we ever read an EKG as being normal or finish evaluating a patient, we kind of run through this differential in our head to make sure we're not missing anything, because this is what can be dangerous when you're evaluating a patient with syncope, and that's what you want to think about. So how do you evaluate someone in syncope in the ER or on the floors? Well, the first thing you want to do is take a very thorough history, a physical exam, and an EKG, because that can yield a diagnosis in the vast majority of patients. The history is crucial. Focus on the exact symptoms before and after the event. Find out, were they sitting, standing, were they hot, were they sweaty, were they dehydrated, had they eaten anything, was there any alcohol involved, were there palpitations before? Try to speak to a witness if you can to corroborate whatever the patient is saying, or if the patient can give a history. Review their medications. There's a lot of offending medications that can lead to syncope. And it's very important to take a family history, ask about a history of sudden cardiac death in the family, sudden accidents, drownings, ask about syncope or seizure disorders in the family that may not have been elicited prior to your conversation with the patient. Elderly patients, I just want to make a comment. They'll often come in and the question is, well, did they fall? Did they trip over something? Or did they have syncope? And if you see an elderly patient that's got kind of bilateral shiners like this, they'll swear up and down that they fell, but you have to have a very high index that they actually had syncope because they're often not reliable in their history. And in elderly patients, syncope is often multifactorial. It can be due to medications, coexisting illnesses that they have, volume depletion, deconditioning. So have a high index of suspicion in these patients, especially if there's trauma involved, because that suggests that they couldn't protect themselves. On the exam, you want to check orthostatics. That's very important for all patients to see if they're orthostatic. That can lead to a very rapid diagnosis in a lot of patients. Check the blood pressure on both arms to look for dissection, coarctation. Listen for a pathologic murmur like aortic stenosis. And in certain patients, you can consider cardiac sinus massage unless they have a bruit or history of carotid disease. And again, before you read an EKG as normal, think about all the EP syndromes we spoke about. Think about them twice and make sure there's no EKG signs of that before you declare an EKG as normal. On an echo, that can give you a lot of information. Of course, you can get LV function. Do they have a low EF? You can see if they have valvular lesions like AS. You can assess for hypertrophic cardiomyopathy. And if you see someone who's got concentric LVH, but no history of hypertension, that's when kind of red flags should go off as to whether or not this patient has hypertrophic cardiomyopathy or any type of LVH really, and no history of hypertension. Now, you, of course, need to figure out, what are the features that make this patient high risk and what are the features that make them low risk? And this is a really nice table from the Syncope guidelines put out by the by our professional society. And you can see that high risk features are older patients, male patients, certainly if you have a history of ischemic heart disease, structural heart disease, if you have previous ventricular arrhythmias. If you have a brief prodrome or no prodrome, so if you just suddenly pass out, that's concerning. Syncope during exertion, so if you have syncope while you're running, that's concerning, whereas syncope after you're done exercising is not as concerning. That's more likely to be due to orthostasis or vagal etiologies, whereas while you're running, it's more likely to be an arrhythmia. Syncope when you're laying down is more concerning for an arrhythmia, opposed to syncope when you're standing or sitting, which is usually orthostasis or vagal. A family history, of course, is more concerning. Now, more reassuring features are if you're younger, if you have no heart disease, again, syncope if you're standing, or syncope, that happens right when you stand up after you've been sitting for a while, that suggests orthostasis. If you have nausea, vomiting, or if you feel warm, that's very suggestive of vasovagal syncope or reflex syncope. And certainly if there's certain triggers for your syncope, pain, emotional stimuli, dehydration, that's again, consistent with reflex syncope. So these are things you can use to risk stratify patients when you're seeing them. Now, most patients will get the basic workup, which is a history of physical, an EKG, and an echo. And after that, you need to decide whether you want to push the workup further. And that really depends on whether you're worried about something else going on that could have been a cause of sudden cardiac arrest. So, for example, an exercise treadmill test can be very useful in patients where you're considering CPVT. If you're worried about their QT interval, if it doesn't shorten appropriately with exercise, that's a concern. Hypertrophic cardiomyopathy or AS can manifest on an exercise treadmill test with blood pressure changes. And certainly if you precipitate VT with exercise, that's concerning. A cardiac MRI can also be very useful. You can see certain scar patterns in patients. And the key thing here is even in patients with a mildly reduced ejection fraction, so let's say on echo, their EF is 45%. It's just a little bit down. But if you see scar on their MRI, that is predictive of ventricular arrhythmias, despite the fact that their EF is not severely reduced. And that's something you have to take seriously, especially if they have something called mid-wall fibrosis. And then there's an EP study, which can lead a lot of useful information in the right patient. An EP study allows us to assess the sinus node, the AV node, his Purkinje function. And that's really because we can measure a His bundle recording, which allows us to assess these intervals. And then we can also try to induce SVT and VT to make a diagnosis in certain patients. Now, an EP study is not the end all to diagnosis, meaning that if I try hard enough, I can take a normal patient and induce VF. And that's just that's just from an aggressive stimulation protocol. And so it doesn't mean that you have VF in real life. And if I can take a patient and do an EP study and say it's normal, and the next day they can have a 7-second sinus pause. So the EP study has some limitations, but it can provide useful information, but it has to be taken within its appropriate clinical context. We can monitor patients. You can get an EKG, of course, which is just seconds of monitoring, a Holter monitor, which is 24 to 48 hours, an event monitor, which can last from 7 to 30 days, and an ILR, which can last from 2 to 3 years, an implantable loop recorder. And this is really great for patients with syncope, especially if they have infrequent symptoms, because you can catch it with long-term monitoring. You may have heard of the Apple Watch and the cardio monitor. That's good for other types of things, but not so much for syncope because you don't have the time to kind of use these devices to monitor yourself while you're passing out, of course. A tilt table test can be helpful in the right patient, but it does have limited sensitivity and specificity, and you have to take that into account when you're ordering one. So now I just want to spend the last few minutes going over some clinical cases that I've seen throughout my fellowship and my career that I think are very instructive. This is a 60-year-old female who was admitted with, who has a history of diabetes, hypertension, and schizophrenia, and was admitted with diarrhea and syncope. And I really love this EKG because you can kind of see on the left hand of the EKG, she has torsades. It's kind of polymorphic VT twisting around its axis. But then on the right hand, you can see exactly why she's doing this. If you look here, her QT interval is severely prolonged. So she had acquired long QT due to psychiatric medications and made worse by her diarrhea and hypokalemia. And so we treated her with pacing and this ultimately, and repleting her potassium and magnesium, this ultimately resolved. So this is an example of long QT syndrome, acquired long QT syndrome. This is a 20-year-old male who came in with syncope while running. Again, that's more concerning than syncope after running. He had an ECG and an echo, which were normal. And so we decided to do a treadmill test. And you can see he had something that we call bidirectional VT. It's kind of hard to see this EKG, but the VT is positive, negative, positive, negative, positive, negative. That's very classic for catecholaminergic polymorphic VT or CPVT. And then you can see this degenerated into ventricular fibrillation with ongoing exercise. And so this, again, is a genetic mutation that involves calcium handling, and he ultimately underwent an ICD for secondary prevention. This is a 22-year-old male who came in with syncope. This is his presenting EKG. He had an echo, which was normal, history, which was unconcerning. And you can see this EKG looks pretty normal, except the PR is short. But some young patients can have a short PR. It's not necessarily benign. They just have a slick AV node. But then he had a second ECG. And now if you look closely in V2, V3, especially V4, you can see that there's some slurring of the onset of the QRS. So now this is very suspicious for WPW, for Wolff-Parkinson-White. And that's what he eventually had. And he underwent ablation of his accessory pathway, and he was successfully treated. And these patients can get syncope either due to very rapid SVT or, more concerningly, for ventricular fibrillation due to very fast conduction through their pathway. This is a 28-year-old female who had syncope. She had no medical history. She was driving, and she woke up and found that she had crossed multiple lanes. Fortunately, she wasn't injured. She had a huge workup: echo, EKG, 2-week event monitor, normal, EP study, normal. However, her cardiac MRI had a small amount of scar in her septum, even though she had a normal EF, and it was consistent either with sarcoid or prior myocarditis. So we put in a loop recorder, and we found this a few weeks later. You can see here, there's P waves here that are marching through without any QRS. So she was having paroxysmal AV block, and this was potentially related to the scar in her septum. She ultimately underwent pacemaker implantation, has been fine ever since. So this shows you how, you can do an extensive workup, but you still, at the end of the day, an implantable loop recorder can really be helpful in these patients. I love this EKG. It's a 35-year-old male with cardiac arrest. You can see he already has a device here because he's pacing intermittently. You can see a pacing spike. And if you look in V1 and V2, you see ST elevations. This patient had Brugada syndrome, and they present with these classic ST elevations in the anterior precordial leads, V1 through V3. He was found to have an SCN5A mutation, which is a sodium channel mutation, which is what can be causative for some Brugada patients. And this same mutation, which was causing him to have Brugada ST elevations, is also causing sinus node dysfunction. You can see he has a P wave, a P wave. All of a sudden, he has no P wave, and he has a pace beat because the sinus node is intermittently just going to sleep. And it's all due to the sodium channel mutation. This is a 78-year-old male who came in with a history of hypertension, diabetes, and he was and BPH. He was on hydrochlorothiazide and recently had been started on Flomax, which is an alpha blocker. And he was in the bathroom and had syncope. So this is a tough case because he had a right bundle, or he has a right bundle, as you can see on the EKG. But he also, by history, it sounds like he was probably volume depleted because he's on a diuretic and Flomax. So you can handle this any variety of ways. We stopped the offending medications. We had him wear a 30-day monitor. He's been fine since, but it certainly would have been appropriate to consider an EP study or a loop recorder in this situation. This is an 82-year-old male who came in with hypertension and coronary disease, and he was walking in the kitchen or walking to the kitchen and had syncope. He fell and he had an orbital fracture and bilateral periorbital ecchymoses like the picture I showed you. Now, this patient has a left bundle branch block, and that's more concerning because now he's got bifascicular disease instead of the right bundle branch block, which is just one fascicle. So in this patient, you need to be more concerned. And we actually put in a pacemaker which is appropriate as per the guidelines. You could have done an EP study in a loop, but given his very concerning history in his left bundle branch block, I think most patients would have put in a pacemaker, which is what we did, and he's been fine ever since. And just a final note, in patients with syncope and a bundle branch block who have an unrevealing EP study, there was something called the ISSUE trial. They followed these patients for 3 to 15 months, and 22 of these patients, 42% had recurrent syncope, which is due to heart block. So if you see a patient with syncope and a bundle branch block, you have to be very concerned about heart block, and a lot of these patients should be getting loop recorders. So in conclusion, I think when you see a patient with syncope, first distinguish syncope from other etiologies that cause transient loss of consciousness. Then try to figure out, is this patient high risk or not? Do I need to be worried about aborted sudden cardiac arrest? Most patients, you can make a diagnosis with a history exam and basic testing, and that testing is an EKG and echo and cardiac monitoring. For high-risk cases or cases that are hard to diagnose, that's when you want to think about a treadmill test, a cardiac MRI, an EP study, genetic testing, and in a lot of patients, an ILR can be of benefit. Thank you very much.
Thank you, Dr. Patel. That was amazing. So overall, we have seen pacemakers. We talk about the SVT, how to approach them. Now we talk about syncope and sudden cardiac arrest. We have been very thorough with these subjects. Now we're going to tackle these EKGs, which shows wide complex tachycardia. And Dr. Nilesh Mathuria will go ahead and give us a brief introduction how to handle them.
Hello, my name is Nilesh Mathuria. I'm one of the cardiac EP faculty here at Houston Methodist, and I've been asked to discuss wide complex tachycardias, ECG survival of wide complex tachycardias. And I think, as this audience knows, as far as when it comes to wide complex rhythms, really we're dealing with 3 general categories. First and foremost, of course, is VT or ventricular tachycardia. Number 2 would be some sort of SVT with aberrancy, whether that's a right bundle branch block or a left bundle branch block morphology, or a so-called AVRT or atrioventricular reciprocating tachycardia. And that involves an accessory pathway, and conduction actually goes anterograde over the accessory pathway and then retrograde through the AV node. Oftentimes, these patients have some sort of baseline delta wave, which can give a clue that there may be some evidence of pre-excitation-mediated tachycardia ongoing. But generally, these are the 3 broad topics that we'll briefly cover here today. So when it comes to the wide complex EKG, when it comes to VT, one of the initial descriptions that's oftentimes used is that it is not of a typical right bundle branch block or left bundle branch block configuration. So before we start talking about atypical, what is typical right bundle branch or left bundle branch block? And as you see here with the right bundle branch block in the precordial leads in V1, you have your classic bunny ears or so-called RSR prime QRS configuration with V6 showing a terminal S wave. And then conversely with left bundle branch block configuration in the precordial leads in V1, you have a large S wave. And in V6, you'll have a large R wave. So when describing VT or when seeing VT, oftentimes the QRS is not like this. So it may be right bundleoid, meaning it may have an R wave and maybe even 2 little R waves like a typical right bundle branch block, but it does not look like this sort of typical right bundle branch block pattern. Beyond, of course, the QRS configuration, we look at axis. VT, of course, has this classic quote-unquote northwest axis, which we'll discuss further. VT is more specifically, one of the most specific features is so-called AV dissociation, where you actually have the sinus rate or the atrial rhythm going at a different rate than the ventricular rhythm or the ventricular rate. One can see capture or fusion beats during VT. And then occasionally regular versus irregular can give you some insight into the rhythm. Classically, a monomorphic ventricular tachycardia will be fairly regular, while of course an irregular rhythm, let's say due to atrial fibrillation with aberrancy, would classically be irregular. But again, that's certainly not a 100% rule. Here are some examples, at least based on EKG, of the so-called capture or fusion beats. As you see here in the middle of the page on the EKG, the so-called capture beat occurs when you have an ongoing wide complex tachycardia, in this case, which was VT, and then suddenly you see a narrow complex beat, a normal-looking QRS. And what that entails is that's the sinus beat or the sinus rhythm actually able to conduct through the AV node and actually capture the ventricle, creating this normal QRS, versus a so-called fusion beat, where you have fusion between the wide complex rhythm and the sinus rhythm, kind of creating this somewhat hybrid QRS that's not quite narrow, not quite wide, if you will. And then next, we mentioned AV dissociation. So what is that? So again, here you have a EKG with, again, an ongoing wide complex rhythm. But if one were to look at the ST segments, you'll notice that there'd be this intermittent undulation in the ST segment that you don't see in other QRS beats, almost every other beat. And in this case, they actually march out. And what that means is that there's actually more ventricular beats than there are atrial beats, suggesting, again, highly strongly suggestive of an ongoing ventricular tachycardia. And oftentimes, this can actually be really gleaned with practice over time, looking at EKGs or looking at tracings where one can see these little changes in the ST segment, and without even realizing over time, as you start recognizing these features, you'll be able to march a lot of this out and be able to tell if there's AV dissociation or not. As you can imagine, much of this criteria has been developed over many decades. This goes back to Dr. Heinz Wellens over 40 years ago. Some of his initial work suggested that VT would tend to have a wider QRS duration compared to SVT with aberrancy. Of course, AV dissociation would be highly specific for VT, left axis deviation. Fast forward 10 years, in 1988, Wendell et al. Had a paper describing, again, VT morphologies. In their paper, wide complex rhythms with the so-called left bundle branch block morphology tended to be more likely to have VT. And again, they have various criteria listed here, but the bottom line is the wider QRSs tended to be more consistent with VT. Fast forward even further, now roughly 30 years ago, the so-called Brugada criteria was published, and even to this day is oftentimes cited as one of the algorithms that we still use today with regard to identification of VT or not. And here, really the emphasis is on the precordial leads, at least in their published experience, over 90 or really 95+% sensitivity specificity with this algorithm. So I think it's worth spending a few minutes describing this algorithm and how to apply this. So really the first thing is to look at the precordial leads and to see, is there an, quote, absence of an RS complex in all the precordial leads. So another way of saying that is there essentially a deep QS or completely negative complex throughout the precordial leads? And if so, then that would be suggestive of VT. If not, then to look at the interval from the initial component of the R wave of the QRS in the precordial leads down to the S wave. And if that time interval is more than 100 milliseconds, or really more than 2.5 boxes, then that would be, again, be suggestive of VT. Again, back to this concept of AV dissociation. If that is identified, again, highly specific for VT. And then again, if there's morphology criteria for VT present in both the precordial leads, V1 and V2 and V6, then that would also favor VT. So again, this is a relatively simple but still widely used algorithm still to this day, and so this is why I mentioned it here today. Taking it to the next level, we mentioned that the so-called northwest axis is again suggestive of VT. So this is a paper in the Heart Rhythm Journal, one of the EP-oriented journals now over 10 years ago, that looked at the concept of, well, if VT has a northwest axis, let's look at the 112-lead ECG lead that would give us that vector, and that would be the so-called AVR lead. And in that case, if you all recall, the AVR lead, again, essentially points towards that northwest axis. And so if there is an initial R wave in that lead, or even a smaller R wave or Q wave greater than 40 milliseconds, i.e. essentially one box on a standard 12-lead EKG, that, at least in this criteria, was suggestive of VT, with a fairly high sensitivity and specificity of roughly 90%. So again, something to consider when you're seeing these patients in the CCU, ER, etc., and are really unclear as to what's going on. This could be something that could be helpful. So again, kind of shifting gears, we've been talking about VT. So what about SVT with aberrancy? So if you notice here, unlike the other EKGs, here there's a wide complex rhythm, but as you see here, this looks very much like the so-called typical right bundle branch block, the RSR prime pattern. You don't see obvious AV dissociation when you look throughout the ST segments. There's some notching at the end of the QRS, which could be suggestive of some sort of atrial activity, but you see that after every beat. So there is no dissociation. You look at the axis, and it's a fairly normal axis. You look at the so-called AVR lead, and it's completely negative, so the opposite of what we were just talking about. So all of this would favor and be consistent with really an SVT with aberrancy as opposed to VT. And so conversely, looking at atrial fibrillation with pre-excitation, in this case, you see ongoing atrial fibrillation, but you see a completely change in QRS complex from beat to beat. And unlike aberrancy, that tends to create this wider QRS after just a sudden rapid increase in heart rate, here we're seeing the wider QRSs even at the slower heart rates. So again, this is a clue that, again, in a patient like this, that perhaps this ongoing wide complex rhythm is due to pre-excitation and underlying atrial fibrillation. So beyond just these diagnoses, when you're seeing these patients, one has to really consider other etiologies, especially in the inpatient setting. So metabolic situation, medications, toxins can all lead to wide complex rhythms. In the EP realm, sodium channel blockers can certainly lead to this widening of the QRS, especially during tachycardia. And so flecainide, clopaphenone are the most commonly prescribed drugs in this class and should be considered, or at least should be evaluated for. Also electrolyte disturbances, whether it's potassium, calcium, of course, severe acidosis can lead to changes in QRS and of course, patients on hypothermia, not just post-cardiac arrest, but let's say after spinal cord injuries, etc., can see this QRS widening, etc. So these are all things that must be taken into consideration when evaluating these sorts of patients. And so really management, it's guided by the symptoms and by a patient's hemodynamic status. So the one easy thing is if someone's unstable, no blood pressure or marginal blood pressure, one can certainly cardivert or defibrillate. Now, if the patient's stable, that's when you have a chance to get a history, see what's going on, see what medications they may be on, look at perhaps a prior EKG to see if there's a delta wave, etc. If it's a younger patient, look at so-called reversible causes like we just discussed, and then treat accordingly, whether that's beta blockers using different antiarrhythmic drugs, which oftentimes may include IV amiodarone, at least in an acute inpatient setting. But the point is to really take a step back and not be overwhelmed by the immediate situation and try to understand what may be happening to the patient based on their underlying history and whatever data you may have available. And so really with that, I hope this has been useful, and I hope everyone best of success during their training, and thank you very much for your time.
Fantastic approach by Dr. Nilesh Mathuria for wide complex tachycardia. And we move on now with atrial fibrillation and stroke by our speaker, Dr. Miguel Valderrabano.
Thank you very much. I'm going to share my screen, and we're going to be discussing atrial fibrillation management and stroke prevention. So what is atrial fibrillation? Just a brief definition. Obviously, by now you should know what this is. It's a disorganized electrical activity in the atria, most commonly, but not always, initiated by ectopic beats arising from one of the pulmonary veins, but maintained by multiple waves of activation in the atria that are chaotic and disorganized, and that lead to an irregular ventricular response. It is important to understand this mechanistic paradigm in order to understand how we treat it with ablation. It's not just a rhythm disorder, it has serious implications to the patient's prognosis because it's associated with an increased risk of stroke as high as 5 times compared to patients in normal rhythm, and it's associated with an increased mortality. We diagnosed it based on the EKG with the characteristic lack of atrial activity and an irregular ventricular response. But more recently, there's been advances documenting that you can diagnose atrial fibrillation using wearable watches. And this is the Apple Watch study that was able to diagnose atrial fibrillation in patients that were asymptomatic without palpitations. Now, with a yield that was relatively low and a lot of false positives, but the point here is that we're going to be seeing more patients diagnosed with atrial fibrillation based on wearable technologies. Even more interesting is the idea that you can diagnose atrial fibrillation in patients that are in sinus rhythm. And this is based on work led by Mayo Clinic, where they use a standardized, digitized 12-lead EKG in sinus rhythm and develop an artificial intelligence convolutional neural network to identify the electrocardiographic signature of atrial fibrillation in patients that were in sinus rhythm. So that is diagnosing AFib before it happens. And this was based on a large data set of almost 200,000 patients with more than 500,000 EKGs in normal rhythm. And then they follow these patients and they diagnosed the signature of AFib in patients that were still in sinus rhythm. Now, don't ask me what that was, because that's the way AI works. It's important to understand some definitions of atrial fibrillation. Paroxysmal atrial fibrillation is AFib that terminates spontaneously or with intervention within 7 days of onset. Persistent is AFib that lasts for 7 days or more. And long-standing persistent AFib is an AFib that's there for continuously for more than 12 months. Permanent atrial fibrillation refers to the situation in which the patient and the physician decide that they're not going to treat the patient's atrial fibrillation. They're going to focus on stroke prevention and rhythm and rate control, but not to attempt to restore normal rhythm. What are the treatment goals in atrial fibrillation? And number one is symptom suppression and improvement of the quality of life. Number two, improve outcomes. Obviously, we want to prevent strokes, and that's one of the first priorities when you approach a patient with atrial fibrillation, is a risk assessment of the stroke risk. And we want to prevent tachycardia-induced cardiomyopathy, prevent dementia, reduce mortality. And the approaches are broadly characterized as rhythm control. That means attempt to restore normal rhythm, or rate control with anticoagulation. If you attempt rhythm control, what can you do? Well, you can use antiarrhythmic drugs, or AADs. And the problem with the drugs is that they're very tricky to use. And depending on what kind of structural heart disease is underlying, you may get into serious trouble. You can increase mortality if you use class 1 drugs. So class 1 drugs are restricted to patients without structural heart disease. If you have structural heart disease, depending on whether it's coronary artery disease, you can use dofetilide or sotalol. But if you have heart failure, only amiodarone or dofetilide are safe. Mind you that catheter ablation is appropriate as strategy for rhythm controlling all spectra of structural heart disease. Now, should we attempt rhythm control or just focus on rate control? For many years, there were several trials that looked at the comparison between rhythm and rate control and had shown equivalence, or no advantage of trying to restore normal rhythm. These were all trials that had short follow-up. But last year, the EAST trial randomized patients to either early rhythm control versus usual care. And the early rhythm control included not just ablation, only 19% of the patients had ablation. So this was not an ablation trial, but also included antiarrhythmic drugs and cardioversions. In any event, attempts to restore normal rhythm. Turns out that on long-term follow-up, cardiovascular death, stroke, hospitalization for heart failure, or acute coronary syndrome were reduced in the patients randomized to early rhythm control. And how about ablation as a first-line treatment? Well, there's more and more data. Very recently this year, 2 studies randomized patients to ablation with cryoablation versus drug therapy, and both of them showed superiority of ablation in the primary endpoint, which was the first recurrence of any atrial tachyarrhythmia lasting 30 seconds or longer. So we know that ablation does a better job at restoring sinus rhythm than antiarrhythmic drug. The question is it worth it based on the invasiveness and the risks? Because an ablation comes with a price, the price of complications, which are there. Like in any invasive procedure, nothing is free. Pericardial bleeding and tamponade, 1%, TIA or stroke, 1 in 500, atrial fistulas, which could be deadly, phrenic nerve paralysis, pulmonary vein stenosis, and others that you can see listed. Ablation, like any other invasive procedure, is not risk-free. And it's mandatory to manage the associated conditions that come with atrial fibrillation. Obesity is one of them. Obesity increases the risk of atrial fibrillation. Mechanisms have implicated pro-inflammatory epicardial fat in the left atrium, but also an association between obesity and hypertension and sleep apnea. There's also an obesity paradox whereby obese patients with atrial fibrillation seem to fare better than lean patients. Bottom line is you need to treat atrial fibrillation by managing obesity because that lowers the recurrence of AFib. Sleep apnea is a fascinating has a fascinating link with atrial fibrillation. Anytime you have a hypopnea or apnea episode, PA pressure increases, right ventricular pressure increases, right atrial pressure increases, and every acute event is associated with an increased risk of atrial fibrillation, but also there's a cumulative phenomenon that occurs with years of sleep apnea that lead to progressive structural remodeling. Alcohol has recently been recognized as a very, very important link with atrial fibrillation. I mean, that's not new. We know about holiday heart syndrome for many years, but what we know is abstinence of alcohol can actually be protective. This was a big study in the New England Journal last year showing that recurrence could be basically halved by hazard ratio of 0.55 in patients that followed abstinence of alcohol versus those that continue to drink as they usual. Do we know that ablation improves survival? There's 2 studies that showed clear improvement in survival after ablation, but those were limited to patients that had low ejection fractions. So the ATAC study and the CASTLE-AF showed that hospitalization for heart failure, death from any cause, or the combination of those were significantly reduced by ablation. In other scenarios, just all comers, the Cabana trial tried to look at mortality and hard endpoints comparing ablation versus rhythm control with antiarrhythmics, and only death or hospitalization were statistically significant. The other endpoints were not, due to in part to the very large amount of crossovers in the study. So when is ablation appropriate? When the benefits outweigh the risk, and that requires a very careful individualization. You have to understand AFib heterogeneity, the symptoms, the burden, and the structural heart disease are very different from different patients in atrial fibrillation. One thing is the marathon runner in their 40s that has 5 minutes of atrial fibrillation, and a very different thing is the patient with persistent AFib in their early 70s with hypertension, diabetes, and apnea. Depending on the underlying structural disease, antiarrhythmic drugs may be more or less attractive for patients, and the ability for patients to accept the risk of an ablation is different across the board. So you have to individualize, treat, of course, associated conditions, and consider that ablation is not always successful depending on the nature of AFib and the presence of structural heart disease. A few words about stroke prevention strategies. The idea here is that patients that are at risk need systemic anticoagulation with either warfarin or NOACs, and patients that cannot take anticoagulation can benefit from appendage closure with either the Watchman or other devices that are in different stages of evolution. But selecting the right strategy requires individualization of risks and benefits. The first thing we need to do is assess the risk of stroke in atrial fibrillation. A priori, the higher the risk of atrial fibrillation-related stroke, the greater benefit of appendage occlusion. And we use the CHATRA score to assess the risk of stroke in AFib. The C stands for history of congestive heart failure. H stands for hypertension. H, more than 75, you get 2 points. More than 65, you get 1 point. Prior stroke or TIAs, you get 2 points. Vascular disease, you get 1 point. If you're female, you also get 1 point. But you have to understand that there's no role of the left atrial appendage in determining stroke risk. There's no factor associated to this scoring system that links mechanistically the appendage with stroke assessment. What we do know is that the risk of stroke is decreased by anticoagulation, and that any of the new anticoagulants does a better job than warfarin, particularly at reducing hemorrhagic stroke, not so much at reducing ischemic stroke, but also reducing bleeding and even mortality in the case of Eliquis. So NOACs have become the standard of care in patients with atrial fibrillation and sufficient risk of stroke. But for those that cannot take anticoagulation, we have the ability to close the appendage and at least address the protection of stroke that comes from the appendage. And I remind you that that's not the only risk of stroke the patient with atrial fibrillation may have, because there's coexisting coronary disease and cerebrovascular disease. So to summarize, atrial fibrillation is a complex disease with important prognostic implications: stroke, dementia, heart failure. Treatment of associated obesity, hypertension, sleep apnea, and alcohol use is mandatory. Novel diagnostic tools can improve early diagnosis and treatment of atrial fibrillation. Early rhythm control strategies lead to better outcomes. Ablation continues to improve and has favorable outcome impacts in patients with atrial fibrillation, including as first-line treatment. And stroke protection strategies have improved with NOACs and appendage closure. Thank you very much.
Great, that was awesome talk by Dr. Miguel Valderrabano about AFib and stroke prevention. Now we're gonna answer a question that came from the audience, and the question: when would you consider an elective cardioversion after a catheter ablation for an atrial flutter, and what's the recurrence rates of atrial flutter post-cardioversion? So the treatment of choice for atrial flutter is catheter ablation as a first line. When it cannot be done, then you should consider the potential of a cardioversion. Or there are certain scenarios that you prefer because the patient has very critical ill at the moment, or the patient refuses any invasive procedures. That is when you should consider the possibility of a cardioversion over catheter ablation. The recurrent rate of atrial flutter is elevated after cardioversion, has been described to be in the next 6 months to be up to 55%. As now, we will continue now with the next session. It will be pacemaker and ICD troubleshooting. And we basically, we're gonna be focusing on Boston Scientific. Last year, we mentioned Medtronic. And we'll go over the basics, programming, and troubleshooting for this company. For this, we go ahead and start.
Welcome everybody to our Methodist Fellow Boot Camp 2020. My name is Paul Sherman. I'm a cardiac electrophysiologist here at Houston Methodist. And today we have planned a great session with Boston Scientific, where we go over the basic programming and troubleshooting that you need for your training. Here, I present to you Trace Holt. He's one of our experts leading in this field, and we go over a few steps. Tracy, why don't we start with some of the basics of the magnet use?
Good morning. It's glad to be here with you this morning. What we're going to talk about is use of a magnet for managing implantable pacemakers and defibrillators. You're going to get asked this a lot, and sometimes it gets a little confusing. But the way I like to remember it is a magnet affects pacemaker pacing, a magnet affects defibrillator defibrillating. Okay. So if I take a magnet and I place it over a pacemaker site, it will basically pace at 100 beats per minute, okay? The important thing about that is, one, it tells you the battery and it's functioning properly, but it's sometimes used during surgery where you want to pace and not inhibit. They're using electrocautery tools. You could place a magnet on there and it would pace at 100 throughout that surgery. For defibrillators, different. You place a magnet on a defibrillator, it basically turns the defibrillator off, has no effect on pacing. As long as the magnet is taped to the defibrillator, it will not shock the person, and that, once again, that would be important during surgery where they're using electrocautery tools. They want to inhibit the defibrillator, but then right when surgery is over, they take the magnet off and it's back on normal function.
Excellent. A quick guide to know if you're dealing with a pacemaker defibrillator is to look at the x-ray. If you see a larger can, usually it's a defibrillator, smaller can is a pacemaker. The presence of a coil suggests a defibrillator, and no coils in the lead means it's a pacemaker. That's a quick troubleshooting trying to find out if you're dealing with a pacemaker and defibrillator and you're about to put a magnet on somebody. Let's talk about basic programming. Why don't we start with interrogation, Tracy?
Okay,
Can you guide us
interrogation.
through the process?
Right here I have a Boston Scientific programmer, we call it, and that's used to interrogate a pacemaker defibrillator, make changes, look at episodes and things like that. Every company has them. They're usually dispersed throughout the hospital. So I recommend you find out where they are and learn where they are, so when you need one, you can grab it. We're going to go over some basic functionality this morning to kind of get you comfortable with the use of grabbing this programmer and actually using it on a real patient. All machines are going to have a wand. Usually you're going to have to find out where the device is, place the wand over the device. In this case, I brought an example one. And then you'll hit quick start on ours. That identifies the pacemaker. And then it will go ahead and load up the appropriate software for that pacemaker. So that's the basics. All of the companies are similar. find the device, put the wand on it, interrogate, it will load the software for you. And then we'll go into some of the basic functionality that we're gonna get into with today. So our screen comes up, and most do come up to a summary screen where you get a quick look at the rhythm at the top of the screen there. Are they pacing? Are they sensed? Patient info, and just kind of an overview of all the settings. So what kind of change do you kind of see?
Well, first of all, I think it's important to look at the events. And before we do any change in the setting, I would like, why don't you guys do the process of identifying rhythm disturbance or something has recently happened?
So basically, I go into the events tab, and you'll see an arrhythmia logbook, and then you'll see a list of any tachyarrhythmias or episodes that have been stored. In our particular software here, the structure is the magnifying glass takes you to more detail. So you could actually click on the magnifying glass, it would load up that episode and then show basically the electrogram, if you will, of that episode. In this particular case, it was just noise because it was not implanted in anybody in this particular case. But you're going to be able to scroll through and see a list of different types of arrhythmias. This one is a mode switch for atrial fibrillation, etc. You can see that's just noise as well.
Perfect. So this is an important feature that we can have, is to identify a rhythm disturbance in time specific. So if a patient has symptoms, we can basically go back and correlate the presence of a rhythm disturbance or a shock or something in the present. Now you may get called to identify that. Now why don't we go over we have ruled out any important rhythm disturbance. Why don't we go over the basic interrogation parameters that we need to know on a pacemaker: capture, sensing, and threshold. Okay.
So probably if you go to the setting or test screen, you can actually run through the tests. But more importantly, the function of a pacemaker, you're going to be interested in the sensing. Is it sensing appropriately? And how do you make adjustments to the sensing? And is it capturing appropriately, and how you would make quick adjustments to the capturing? So essentially, if you go to the Brady settings here, you'll see it's pretty straightforward there on the right side. You'll see the amplitude or the output. If you suspect loss of capture going on, you can just bump that up immediately to max output and hit program. And that if that is the problem, it would solve it immediately. You could do it on the atrial lead as well, hit program, and hopefully if that's the problem, that will fix it immediately. If it's under sensing, you can come over to the sensitivity and you can change your parameters that make it more or less sensitive depending on what the issue might be.
Excellent. So we have gone over the management and programming for sensing troubleshooting and pacing troubleshooting. It's very important that we make a little bit of distinction on the mode of the pacing. Tracy, would you guide us through the changing the mode from DDD to VVI?
Sure. So in this particular mode, DDD, it's the ventricle is going to follow the atrium and it's going to track their own rate, and they will pace as needed on demand. In some cases where they're in AFib and you don't want to track the AFib and maybe it's not switching automatically, you might come over and change your mode to DDI, which is a pacing mode that kind of controls the A and the V separately. It's really just watching the AFib and pacing the ventricle on a regular basis.
So basically we have eliminated the trigger function or the acting function of a pacemaker based on an atrial signal. Excellent. How do you guide us if we want to check the impedance of this device now?
Okay, so if you kind of go back to the main screen, you'll see a tab called Tests. And you can actually run the intrinsic amplitude test. And that test would be important to understand your sensitivity settings we talked earlier. This one has no sensing because it's not hooked up to a real patient, so I'll cancel that test.
Perfect.
But you can run down and you can check impedance. Impedance would be important, as are the leads, integrity of the leads in the circuit, the pacing circuit. And if you wanted to, you could do an atrial threshold and ventricular threshold as well.
Perfect. What about the battery? If somebody asks them how much battery we have left.
The summary screen, when you first logged in, you've got in the bottom left, a battery indicator, and that tells you how much time you have left on your battery.
In this case, you can see there's about 1.5 years. So excellent. We have gone over the programming, basics, thresholds, and parameters that you need to know. Why don't we talk a little bit about thresholds, captures?
Okay.
How we do that, and also if you can mention what's the easiest way to see if somebody's pacer dependent.
Great, that's a great question. So let's do that one first. So I have the ability to come to a temp screen All programmers have this. And so I could just say, let me change it to just pacing at a lower rate of 30. And then I would hit start. And basically, I'm going to find out, are they going to be paced at 30 or is their own rhythm going to come in? If they're paced at 30, we would call them pacemaker dependent. If they have their own rhythm coming in, we'll understand whether they're bradycardic or whatever.
Excellent. That's a simple way to find out if somebody is dependent or not on a pacemaker. And remember, this could be intermittent. You may have some intrinsics one day and another day you may not. But it's important every time that you handle a patient interrogation that you've tried to figure out if the patient is dependent or not, okay?
And then next you talked about tests. We were on the screen before in the lead test. I showed you the sensing, I showed you the impedance, and you could actually go into what we call a threshold test. And basically it starts out at a certain voltage and it'll do a voltage decrement until you lose capture. And you really need to be careful here if they are dependent, because you can lose capture and go asystole. So it's kind of you need to make sure you know what you're doing. But essentially you start it and it will just decrement down until you observe loss of capture, and then you end the test.
We're recommending this part if you feel unsecure that you try to do this first of all with somebody who is trained. With this video, the idea is to give you some of the basic knowledge and fundamentals, so then you can meet with one of your local rep and try to practice these skills with the programmer. So when you're on call, you're needing, and you don't have somebody with the expertise available, you are able to manage and do the proper care for the patient. Excellent. So for summarize now, let's imagine that you get a phone call from a patient in the hospital, but you are outside and you need to get some remote information out of the patient. Why don't we, Tracy, talk a little bit about remote monitoring and your portal and how to get that information on?
Okay. All the companies have an internet-based application that, and most patients have a monitor at home that talks to the device on a regular basis, transmits the data to this database system. And then you can get access to this system in the hospital and clinic that you're working with. And it's very helpful. You can go in and see historically all the settings for the patient, the arrhythmias for the patient, and pretty much anything you need to know about this patient. So every company has the portal. You just need to find out the URL to access it and get you an account set up for that.
Excellent. In this case, his name is Latitude for Boston Scientific. You should contact your local rep or anybody who is within the EP service that can give you some help in accessing this remote transmission. Sometimes you might find that it's scanned on the medical records, but it's a very helpful information to have it ready for your call.
Yeah, and some places that I find this helpful, of maybe just one scenario, a patient's at home, they said they think they got shocked. You could have them push the button on the monitor, come in, log into the system, find them, select the patient, and it'll tell you, did they get shocked? And you'll, just like you do on the programmer screen, you can go in and look at the episode, find out was it VF, VT, AFib with RVR, etc., and basically manage it remotely without the patient even having to come in.
Excellent. I think we're going to stop here and summarize. Thank you for attention, and I hope this will help you in your practice. Hello, everybody. That was a great talk about Boston Scientific overviews, and we have reached the end of our program. And it has been 2 amazing days for this learning of the Cardiovascular Fellowship Training Program. And I believe it contains the right knowledge to get you ready to start your fellowships. We would like to thank the boot camp directors. We'd like to thank the physician staff who participated in this. We'd like to thank the Houston Methodist Cardiovascular Fellow programs. And we would like to thank you, the DeBakey Cardiovascular Education Studio, and all the participants in this program.
In the meantime, we encourage you to access and review all the content on our channel. All the content that you saw yesterday and today, you can see whenever you want to on the YouTube channel. So if you're on call or you're just at work and you want to review a specific topic, they're nice bite-sized pieces to review. We really look forward to seeing everyone next year in 2022 at our next Fellows Boot Camp. Thanks for joining us today.
Thank you, everybody.